Everyone, and a huge warm welcome to this Bronchiectasis Patient Conference. I'm unfortunately Pippa Powell, the ELF Director, and I say unfortunately because I should be Dimitris Kotopidis, the ELF Chair. Unfortunately, he's been in hospital this week, so he's asked me to join your conference just to say a warm welcome and hello from the European Lung Foundation. He particularly wanted me to do that because his fellow Greek patient advocate, Elisa, is co-chairing one of the sessions today, and he really wanted to show his support of our Bronchiectasis Patient Advisory Group and all the work that they've done to put this conference on today. So just a few words on the European Lung Foundation. So we are an organisation led by patients, and we work with patients across the globe to bring them together with healthcare professionals and to improve lung health. So we focus on advancing diagnosis, treatment and care for lung conditions, and conferences like these are one of the ways in which we do this. So we hope today you'll be able to learn more about your condition, ask questions directly to experts, but also it's about experts learning from patients and sharing their personal experience about their lung conditions. So our first ever patient conference was in 2021, and it was a bronchiectasis patient conference. And ever since then, we've been hosting them on a range of different conditions. Many patients, along with their families and friends, have told us how much they've learnt from these events and have told us that it makes them feel less alone. It's a really great opportunity to also see how dedicated all the healthcare professionals are to improving care and treatment of us all. We recognise that there's many healthcare professionals in the audience today as well. We know they're eager to deepen their knowledge and enhance their ability to support you as patients with bronchiectasis. So from the whole European Lung Foundation team, from Dimitris in particular, and from myself, we wish you a really enjoyable event. After the event, we'll send you out a survey so that we can gather your views and you can tell us what you think. But thank you very much for being here, and I'll hand over to the chairs now to start the conference. Thank you very much.
Hello, my name is Donatella Nobile, and I would like to welcome you to our first annual Bronchiectasis Patient Conference. Before I tell you a bit more about myself, I want to tell you about the translation app that we are using today. It's called Wordly, and it provides automatic translation in over 16 languages. We have posted the link in the chat box, or you can scan the QR code on the screen. When you access the app, first select the language you want from the drop-down list and then click Attend. Wordly will open in a screen and you can position in it analogized side webinar to view both screens. You can read the transcript on your device or use a handset to listen to the audio. We know that automatic translation is never perfect, and some of the words and phrases may not be quite right. But we hope will help. We hope but we hope that we help make this conference for more accessible for many. If you have any problem accessing the app, please send an email at info@europeanlung.org and a member of ELF team will help you. Okay, now I will tell you a bit about myself. Hello, everybody. I'm Donatella. I'm from Italy and I have bronchiectasis. I know this disease from when I was young because my sister had bronchiectasis. I'm very happy to be here today. I remember the experience of my first conference, which really opened my mind to the world of bronchiectasis. I was very curious, but also a little bit difficult because English is not my mother language. However, thanks to the speakers, I understood everything. So, 2 years ago, when I was asked to join the Passion Advisor Group, it was a natural choice. We meet about once a month, and we discuss and organize various events to deepen our understanding of bronchiectasis in war. I'm also a volunteer with the Italian Association of Bronchiectasis. I'm not alone. Today, I will now hand over to my co-host, Dr. Peter Gammon, to introduce himself.
Thank you, Donatello, for introducing me. I'm Peter Goumene, respiratory physician in Belgium, located in Sint-Niklaas, and a bronchiectasis enthusiast. And I have the honor to do some housekeeping while people are still coming in, already 300 attendees, but there's certainly more to come. So do bear in mind that we have a webinar. So this means that you can only see the speakers and the chairs and the host. You cannot see other participants because of privacy reasons. Of course, everybody's on mute, so you can scream as much as you want. We can't hear you, but if you have anything you want to ask, there is a chat and there is a Q&A where you are really invited to participate. For the Q&A, please write your questions for the speakers in the Q&A board down below in your screen. We will try to answer as many as we can in the time we have, and those that are not answered, we will try to answer them later on by asking the speakers these questions. Don't forget, these are expert clinicians who will be answering your questions, but please keep in mind, because I already saw some questions, we cannot answer the questions about anyone's personal circumstances or cases, so try to frame the question in a general way, okay? There will be also some polling, as you can see here on the screen. We will use several polls to keep you engaged, and you are really invited to take part in them. If you are an avid social media user, then tweet or X using the hashtag Bronchiectasis2025, and please tag the ELF, the EMBARC, and the European Respiratory Society using the tag handles that you can see on the left bottom of the screen. Also very important, because I already saw some questions about that, the conference is being recorded and talks will be made available on the ELF website and the ERS Respiratory channel after the event. It will take a few weeks, almost 2 weeks, I think, to have the recordings on the website. So Donatella, I'll hand back to you to talk a little bit about the collaborations.
Today's conference is organized as a collaboration between the European Lung Foundation and EMBARC. You can find out more this organization at the link shown on the slide. We especially thank the member of the Health Bronchiectasis Patient Advisor Group PAC who organized family members. And a special thanks go to Bridget Harris, who represented the PAG on the planning group of this conference. We also want to pay tribute to Barbara Close, a member of our PAG since 2017, who sadly died last year. Many of you who have attended our provision conference will remember Barbara, who always took a role in planning the conference and inspired many people by sharing her own experience. She was a passionate advocate of raising awareness of bronchiectasis, and in particular the importance of airway clearance, exercise, and self-management. Would like to dedicate this year's conference to the memory of Barbara. So, Peter, next.
Yes, looking at the many heart emoticons that appear, I think Barbara is truly missed. She was a really supporter of the bronchiectasis community and helped in a lot of ways. So Barbara is really missed. Thanks to Barbara and many others, this patient conference has grown throughout the years, and our audience today is made up not only of patients with bronchiectasis and family members, but also we welcome healthcare professionals, medical students are there, patient organization representatives and members of the public who just joined us to have more knowledge about bronchiectasis. We had over 1,104 registrations from over 80 countries, so a massive success throughout the whole world. So again, please put your questions for the speakers in the Q&A box, but again, remember, we cannot really answer questions about anyone's personal circumstances or cases. Also, please like any questions in the Q&A that you want most answered, because then the thumbs up icon will show up and we will flag them up for attention. And this might also help avoid duplication of questions. And then maybe a little bit more about the outline of today. We have a mix of patient speakers. We have a mix of professionals in the field who will speak about bronchiectasis. It's going to be after our welcome, the first session about bronchiectasis overview. There's going to be a short break. Then can my bronchiectasis be helped? Then a short break. And then in the afternoon, we will continue with self-management and well-being and finding the answers and research and the future. You can access the program if you want to revisit that by clicking on the resources icon on the bottom of the Zoom screen, but it's also available on the ELF website. We'll put the link into the chat. So again, 4 sessions, 2 co-chairs, a patient and clinicians who have a nice balanced overview. And after each session, there is time allocated for questions. And Donatello, sorry, if you want to continue with maybe a first poll.
Yes. The first poll, please. Thank you, Claire, for this and put the poll. The first poll of the day, we asked you to answer for your knowledge of bronchiectasis, where number 1 is not known and 10 is extremely large. Please answer and wait this. Wow. 300 people, and we have a number 5, so just a good knowledge of bronchiectasis, but I'm sure after this day they will know the number from become another, for example, 7. Why not? Now we hand over the co-chairs for the first session. So Justin and Mattia, who we will introduce themselves to you. Thank you.
Hi. So, good morning, everyone, and welcome to this Bronchiectasis Patient Conference. I'm Justine Amaïd. I'm French. I live in Paris. I am a patient. I have bronchiectasis and NTM, non-tuberculous mycobacteria, and I founded the French NTM organization. It's called MNT, Mon Poumon, Mon Air, 2 years ago. Finally, I joined the ELF Bronchiectasis Patient Advocacy Group last year in September. And today it's a pleasure to co-chair this first session with Dr. Mattia Negro. And I leave him the floor to introduce himself.
So thank you, Justine, and thank you, everyone, for being here. It's such a wonderful occasion to discuss between doctors and patients on bronchiectasis. I'm really happy to be here with you. I am Mattia Negro. I'm a respiratory consultant in the Humanitas Respiratory Hospital, Humanitas Research Hospital in Milan, Italy, and I'm a PhD student at Humanitas University in Milan. And it's a wonderful occasion for being here, and I hope we'll have lots of discussion about the topic we're going to face today. I would start with introducing the first speaker of the first session. That is Professor Michael Steinberg. So it's a pleasure for me to introduce her. Michael is a clinical associate professor and the head of bronchiectasis and nodal cystic fibrosis units at the Carmel Medical Center and the Technion Israel Institute of Technology. She is also the lead of the patient activities work package of EMBARC. Michael's main interests are bronchiectasis and its overlap with other respiratory diseases, and she will provide today an introduction on bronchiectasis. So please, Michael, the stage is yours.
Thank you very much, Mattia, for this very kind introduction. And I'm really looking forward to this edition of the conference going on for the 5th year. I'm looking forward to a great day. So my job here today is to introduce what bronchiectasis is, the basics of bronchiectasis. And these are some disclosures. You will have to know that I do some work for a pharma company, for which I get paid. So this may have perceived conflicts of interests. So I frequently get asked from patients newly diagnosed with bronchiectasis, what this is bronchiectasis, how it's diagnosed, and the symptoms, what exacerbations are, and what do we know about causes of bronchiectasis? My patients want to know, why did I get bronchiectasis? And most importantly, how we treat it and how we can improve the situation of patients. And there's a lot to be done. And I think my message here is an optimistic one, that we have a lot to be done. So I'll start with a poll just to get people rolling. What percentage of adults do you think have bronchiectasis? So please start voting. And while you're at it, I'll mention that I know that a lot of people will know what hypertension is or elevated blood pressure. They know what diabetes is. They know what asthma is, but they may have never heard about bronchiectasis. So people think it's very, very rare. Please, I'm just not seeing how many can voted already. So just tell me when we can close this poll. So Claire, when you think we had enough votes, please show. Okay. So about 20% of you think it's 10%. 44% think it's 3%, 29% think it's 0.4%, and 7% think it's very, very rare. And we'll see in a minute what the current estimates are. So what bronchiectasis is really, it's a disease of the airways. It's a chronic, lifelong, daily disease with symptoms, and it has flares once in a while, flare-ups or exacerbations. The man in the pretty picture on the right is the physician that described bronchiectasis for the first time. His name is Rudolf Theophil Lenneck, and he invented the stethoscope. So this picture really shows him using his new invention to examine the chest of a child. And in 1819, he described bronchiectasis, but this disease was pretty much forgotten about and neglected until about 2010, 2012. It's not very rare. The prevalence, or how many people, the percentage of people who have bronchiectasis, is between 0.25 and 0.5% in adults. So not extremely rare. It translates into about 10 to 20 million people in the world. And just for comparison, cystic fibrosis, who more people may have heard of, is much less than that. It's only about 80 to 100,000 people. But bronchiectasis is less common than asthma and COPD, which are both between 5 to 10%. So not very rare, not very common disease. So what bronchiectasis is, it's really a disease of airways, and this diagram on the left shows what a normal lung is. And you see these tubes. I hope you can see my pointer. You can see these tubes going in the lungs. There are actually many more tubes or bronchi that we see here. And you see that they're really like tubes and going in and out. And this is the tubes that the air goes in and out through, but they also have a mechanism of self-cleaning. And bronchiectasis is here on the picture on the right. You see that the tubes are really distorted, they're widened, and you see that they're filled with content. And this is the phlegm, or that we call mucus, which really is very typical of bronchiectasis. And we use CT to diagnose. So this is a CT scan, but it's the same position of the diagram that you saw. It looks like a person standing up. This is a healthy lung on the left. And this is a lung with bronchiectasis. And you see here the distorted tubes going to the periphery of the lungs. Usually, when you look at a CT at your doctor's office, you will see the horizontal picture. So this is a healthy lung, and this is a lung with bronchiectasis, and this is what we usually look like. And what happens inside those bronchi is that if this is a normal airway or normal bronchus, it has a really regular wall, and it's round and nice. And an airway with bronchiectasis becomes scarred and stretched and inflamed, has inflammation, and it's also filled with content, with mucus or phlegm. And there are several components to the disease of bronchiectasis. First is the trapped mucus that we showed. Then it's infection, which means that bacteria, viruses, fungi come into this mucus and infect the lung. Then there's inflammation, which means the response of the body, of our own immune system, in white blood cells that flood into these airways. And these were designed to fight infection, but they actually can cause more damage. And the third component is lung damage, what we see on the CT. So each of these components can adversely affect the other three. And this is why we refer to these processes as a vicious cycle or a vicious vortex, where each process is causing the other processes to also deteriorate. And their symptoms. So a few years ago, patients like you were asked to describe their symptoms with bronchiectasis, and we got responses from more than 700 patients with bronchiectasis. And on the right side of the graph, on this graph, you see the percent of the people who described every symptom. So you see sputum is very, very common in bronchiectasis. So is cough and shortness of breath and not feeling fit for daily activities and tired. And you see how common anxiety and depression are. And that's really, I think, a lot to do with a disease that no one really knows about. And to diagnose bronchiectasis, you need to have the symptoms, you need to have the CT, and this is the two components really that we diagnose bronchiectasis with. So why is it caused? What do we know about the causes of bronchiectasis? And this graph describes the many causes that bronchiectasis may have. In the green, you have airways diseases such as asthma and COPD. And my personal opinion is that sinusitis is one of the causes. And then you also have infection like tuberculosis, but also bad pneumonias can also cause bronchiectasis. Gastroesophageal reflux, and you have rheumatologic disease or inflammatory diseases like rheumatoid arthritis or inflammatory bowel disease. And you have genetic diseases such as cystic fibrosis causing bronchiectasis in the lungs, and PCD, which stands for primary ciliary dyskinesia. And some people have genetic deficiency in their immune system, and some have deficiency of their immune system because of acquired causes. And then there's people who we have no idea why they got bronchiectasis, and we call that idiopathic bronchiectasis, which really means we don't know. And we have a lot of information coming from a large registry called the EMBARK registry. It has a lot of information of people with bronchiectasis, more than 17,000 people with bronchiectasis throughout Europe and Israel. And from this graph, you see that about 40% of people are in the blue part of the graph, which is idiopathic, or we don't know why they got bronchiectasis. About 20% are post-infective, and then we have smaller percentages of asthma, COPD, tuberculosis, immune deficiency, and so on and so on. So it's a really heterogeneous disease, which means many causes, and so it's very different from one patient to another. And then we talked about the symptoms, and then there's exacerbations. And I want to start another poll asking you, or only our patient audience, do you experience exacerbations, which are also called sometimes flare-ups? So you can choose between no, my symptoms are relatively stable. Yes, I've had an exacerbation and it was treated at home. Yes, I've had an exacerbation and it was treated in the hospital. Some patients may have had both, so there is more than one choice possible. Or I'm not sure what an exacerbation is and if I had one. So please vote. And I think one of the most important things that we have today is for people to recognize what exacerbations are and to come to get attention. So we'll wait for everyone to vote on that. Okay, so for 12%, people are pretty stable. 65% have had an exacerbation treated at home. 25% were hospitalized due to an exacerbation, and there's 40% who are not sure if they had an exacerbation. So I'm glad I have the next slides coming for those 14%. So if we think about your daily symptoms of of bronchiectasis as a fluctuating symptoms, better days, worse days, and actually pulmonary exacerbations are periods of really worsening cough. So you actually reach below a certain threshold with a lot of symptoms. And when you have 3 or more of the following symptoms, which are cough, increase in sputum volume, increase in the purulence of sputum, so it's darker, increase in breathlessness, or increase in fatigue or malaise, which means sort of when you're like when you have the flu and want to stay in bed all day, or if you have blood in your phlegm. If you have several of these symptoms for 2 or more days, we call that an exacerbations. And this is a graph, is an imaginary one. It shows a patient who has relatively periods of stability and periods of feeling well, and then periods of exacerbations. And not everyone is like that. Some people are getting better. We know that some people are especially at risk of exacerbations, and there's conditions that are associated with more exacerbations, such as when you have chronic infection, when you have a lot of inflammation in your airways, when you have asthma and COPD or rheumatoid arthritis, for example, you will have more exacerbations statistically. But we're less good at determining what really caused an exacerbation or what started an exacerbation. Sometimes we think that it's changes in the bacteria that are in the airways, but research has taught us that it's usually not the case. The bacteria in your airways are usually the same when you're stable and when you're exacerbating. And we think it's more like more about what the bacteria are actually doing. We know that some exacerbations are associated with viruses, viral infection, and we know that air pollution has to do with exacerbation, and we also know that there's more airway inflammation starting an exacerbation. And speaking about the course of patients, not all will exacerbate and not all will deteriorate. Some will stay a bit relatively stable, and some will stop having exacerbations, especially with treatment, and become improved. And I think most patients do. And we have upcoming a talk from Peter Hominy that will tell us the ways that we know if we are deteriorating or getting better. So what can we do to treat bronchiectasis? And actually, we can do a lot to treat it. So when I have a patient in front of me, I want to treat the stable disease, and I want to reduce the symptoms. I want to prevent exacerbation. I want to prevent them from deteriorating. And they have to understand that it's a continued treatment. It's not like a surgery when we treat and that's the disease goes away. It's something continuous that you need to do every day to keep well. When there's exacerbations, we want also to reduce the symptoms and to speed up recovery, but also to prevent complications. So I like to think about the way we treat bronchiectasis as a stepwise approach. If I know the underlying cause of bronchiectasis, I try to treat it. With most cases, I don't. So even, for example, if I have a patient with CF and bronchiectasis, I treat accordingly. Airway clearance is very, very, very important. And I think about 60 to 70% of my patients will get well only with airway clearance. We sometimes add drugs such as inhaled saline, which is salty water, or others. And physical activity is very, very important. And we'll have a talk later today by Professor P.J. McShane speaking about the importance of physical activity. For some of my patients or some of our patients, we use inhaled drugs such as bronchodilators or drugs that widen the airways, or corticosteroids that are directed into another special kind of inflammation. And if people are chronically infected, we use suppressive antibiotics, continuous antibiotics, which could be inhaled or oral, and that depends on the infection. And we'll hear more today from Professor Charlie Harworth about suppressive antibiotics. For the minority of patients who are short of breath, we have pulmonary rehabilitation, and if needed, not very many patients do need oxygen or not invasive ventilation, and a very, very few of my patients would actually get to lung transplantation. And we have a lot coming up in the future, future drugs that are designed to treat inflammation or anti-inflammatory, and drugs that treat infection. And we'll hear more from Professor James Chalmers later on today. During exacerbations, we increase airway clearance to get the phlegm out. We take a new sputum sample just to see if there's a surprising new bacteria. Usually it's the same bacteria that we know the patient have. And we treat with antibiotics, usually for 10 to 14 days. And some other treatments may be suitable for some patients. There's many unknowns to be discovered in the future. How and why bronchiectasis starts for most patients is a mystery still, and how we can prevent it or prevent deterioration is one of our most important things to learn, to have better treatments, and to pinpoint the treatment to the right patients, which is called precision medicine. And I think all of the speakers that you will hear today will touch on these topics. So to sum up, bronchiectasis is an airways disease, is characterized by airways infection, inflammation, and changes in the structure of the airway. It can be caused by a lot of processes and diseases, and it's frequently accompanied by other conditions. We diagnose bronchiectasis by the presence of symptoms, and we refer to a CT scan. And symptoms vary, but are generally cough with sputum and shortness of breath, with exacerbations for some of the people. Treatment is stepwise and it's tailored according to the condition, and most people get very well and better on treatments. So there's a lot to be done, and I think it's a very encouraging disease. So with that, I will thank you. This is my hospital where I work, and the dove represents the peace that we so long for in our area and globally. So thank you very much.
So thanks a lot, Michal, for this brilliant presentation that makes us better understand the bronchiectasis disease that is quite complicated. And you help us to understand how to feel better with or without treatment. And after you will have, I presume, some questions in the Q&A session. And now we will have a video with Joyce Norwell. Joyce has lived with lung problems throughout her life, and she was diagnosed with bronchiectasis in 1987. Joyce is a member of the ELF Bronchiectasis Patient Advocacy Group, and she is keen to raise awareness of the condition and improve the relationship between doctors and patients. So now let's look at Joyce's video.
So I'm Joyce, and I have bronchiectasis with Pseudomonas, and emphysema just been diagnosed as well. People found it odd that I was coughing and not very pleasant to be near because of always blowing my nose and coughing, etc. So yes, so from that point of view, it made me feel very isolated. And I think really that's why I've been so determined through my life that I wouldn't give in. When I get up in the morning, I have a cup of tea just to relax and try and come to. And then I will start my morning regime, which is first of all to take the inhaler, and I take that on an extender so that I can get the most out of my medication. I then do my nebulizer, which is the steam that is going into my lungs to help reduce the inflammation and help me cough. And then I do my breathing exercises. But because now I have the Pseudomonas, which is in the lower lungs, it helps sometimes do postural drainage, which is lying on a slant and letting the mucus drain to my throat so I can cough it up easier. Then we repeat that another time until you can hear that things are beginning to move within inside here. I'm gently tapping with my arms, one side or both together, whichever you find easier. Just gently tap so that you can hear and bring it all the way up to the very top and listen to where you can hear the most rattling, because that's the area that needs concentrated on. As you can hear, there is some rattling going on. So I'm going to try one side, doing the same again. So I breathe in. You can hear the sound is coming here to about here. So that's an area I'm going to work on. And you can keep doing this until, can you hear it coming up? Then stop, take a deep breath and a big huff. That will move it up, and then repeat. When I'm in hospital, or if I'm just sitting around, I have this one which looks very much like headphones, and the cool air is coming up from here, which means it helps me to breathe. And also you can buy them that also have water in them as well, so that you have the steam coming up as well. It is helpful when you go to see your consultant to know what it is you want to talk about, because obviously time is very short. So I always take a list so that I have the things that I want to discuss, so that we have some record, so that the consultant realizes that I'm taking this seriously. This is what I want to discuss, and please, I would like answers. It's a two-way conversation. You are your own expert. You know, you've got the experience of what you're doing. And there's something that's worrying you. You want to know what the next stage is. I've just been told I might have emphysema. I want to know more about that. Yes, it is a shock when you go to the doctor and he says that you've got bronchiectasis. And you think, well, okay, I can take a few tablets and that will go. No, this is a lifetime experience for all of us. And that can be very depressing and very frightening. But as you can see, I hope from what I've said, even as you get older, there are things that you can do and life can be good. Don't be afraid. There is things that we can do in the future. There are people there to help. There are people to understand. And it's up to us to ask and to work alongside them as a team so that we can all make the best we can of our lives and help other people now and in the future.
Wow, that was so emotional. So thank you very much, Joyce, for sharing your experience. It was such an incredible content. Thank you very much. I will proceed with introducing the next speaker of this session. That is Dr. Charles Howard. Dr. Howard is a respiratory consultant at the Royal Papworth Hospital in Cambridge in the UK, and is specialized in treating adults with bronchiectasis, NTM infection, and cystic fibrosis. He has co-authored both ERS and the British Thoracic Society guidelines, and is also a member of the EMBARC Steering Committee and Scientific Committee. He will provide us with a speak on bronchiectasis and long-term infections. And yeah, please, Professor Howard, do this. The stage is yours.
Thank you very much, and I hope you can hear me okay. So as Matteo says, I'm going to talk to you about bronchiectasis and long-term infections. I'm just trying to move the slides on. As Mikhail said earlier, I do some consultancy work with pharma and helping them to design and run clinical trials. This is just so that you're aware of that. So this is a CT scan that shows bronchiectasis, and you can see that the changes here are really quite marked. You can see very dilated breathing tubes or airways. You can see that the airways are really quite thick, and this suggests that they're very inflamed. You can see areas of mucus plugging and areas of infection. And these are the components that we think combine and are interrelated to form the vicious vortex that explains the development of bronchiectasis. And so an example is that someone that perhaps has trouble clearing mucus from their lungs, that leads to obstruction or blockage of the breathing tubes. That then leads to episodes of infection, initially sort of acute new infections, but they can then become chronic. And this leads to inflammation within the breathing tubes. And all of these factors combine and are self-perpetuating and can result in damage to the airways and bronchiectasis. So I want to think a little bit in more depth as to why infection is so important. And this is beautiful work by Professor Chalmers and colleagues dating back to 2012. that shows the relationship between the amount of bacteria within the lungs or within sputum and the amount of inflammation measured by this substance called neutrophil elastase. And this is a substance that's released by immune cells in response to infection. And while it helps to attack infection, it also can be damaging to the airway. And as you can see, as the amount of infection increases within sputum, the amount of neutrophil elastase or inflammation increases. And then further work shows that with increasing bacterial load within the airway, there's an increased risk of exacerbations and an increased risk of hospitalization. And so this really reinforces how important infection is in driving the development of bronchiectasis. So what are the common bacterial infections in people with bronchiectasis? And this is data from the extraordinary European bronchiectasis registry that has approximately 20,000 people within it. And this is data, again, published by Professor Chalmers in Lancet Respiratory Medicine in 2023. And you can see the most common infections are Pseudomonas aeruginosa in about 25% of people, maybe a little bit less for Haemophilus influenzae. And then Enterobacter type species, which are sort of gut-related bugs in approximately 15 to 16% of patients. And then less commonly, bugs such as Staphylococcus aureus, Streptococcus pneumoniae, and Moraxella. And interestingly, there's a geographical distribution in these bugs, and Pseudomonas is actually much more common in Southern Europe, and then in sort of Northern Western Europe, UK, Haemophilus is more common. And so it rather suggests that the environmental conditions within a region influence the commonality of bacteria and hence the risk of developing these types of infections in people with bronchiectasis. What I haven't talked about here are non-tuberculous mycobacteria, because that's a really big topic and would be a whole talk in itself. So for the rest of this talk and discussion, I want to think about how we use antibiotics in people with bronchiectasis. And there are really three main areas. One is for treatment of exacerbations. The next is for chronic suppressive or maintenance antibiotic therapy. So antibiotics taken either daily or 3 times a week as a long-term treatment. And then there's eradication treatment for when we find a new difficult bug for the first time and try to get rid of it. So I'll go through these one by one. So for pulmonary exacerbations, and this has been touched on by Mikhail already, it's really important to distinguish between what are steady state symptoms and normal fluctuations, and then periods of exacerbation. And I would suggest that exacerbations are characterized by symptoms usually over days, but it can be over a more prolonged period, a more gradual deterioration. And it may be that people initially have viral symptoms, perhaps a sore throat or sore sinuses, but that then leads to an increased cough frequency, increased sputum volume and purulence, and maybe thickness of the sputum, maybe tightness of the chest, wheeze, breathlessness, and possibly aches within the lungs, a bit of streaky hemoptysis or worsening hemoptysis, night sweats and temperatures. And sometimes these episodes can just self-correct spontaneously. You may do your airway clearance a bit more often and things settle down. But if after 3 or 4 days there's a gradual and continuing decline, then that normally means that this is an exacerbation and something needs to be done to try and improve things. So there are a few things that distinguish treatment of bronchiectasis from other common respiratory conditions such as a COPD exacerbation or an asthma exacerbation, or just a simple chest infection in an otherwise healthy person. And in bronchiectasis, you generally need higher doses of antibiotics than just the standard lower dose that a GP might prescribe. Bronchiectasis exacerbations usually need longer treatment courses. So 5 days that a GP might give to someone with COPD usually won't be enough in a patient with bronchiectasis. And antibiotic treatment should be guided by previous sputum cultures. So you're probably aware that your specialist likes to get a sputum at times of when you're in steady state, but also during exacerbations, because that gives us a library of information about what's happening within your lungs, and then that can guide treatment in the future. Ideally, you should have an antibiotic course at home so that you can start antibiotic treatment promptly, because certainly in some healthcare situations, it's difficult to get to see the doctor quickly, and so having your own treatment course at home is very helpful. If it's possible to submit a sputum culture before starting antibiotics, that's very helpful, because if your treatment isn't working, at least you've got then some information to guide future treatment. But I would only change your antibiotic when you get a positive culture if you're not getting better, because if you're getting better, there's no need to change. So these are the sorts of antibiotics that we use to treat exacerbations. If you tend to culture Haemophilus or Streptococcus, then amoxicillin or doxycycline can be helpful. If you have a more resistant organism, then Kermoxiclav can be beneficial. If you culture Pseudomonas, we often use an antibiotic called ciprofloxacin. And if you have MRSA, then we use antibiotics such as doxycycline or rifampicin or linezolid. And if you're particularly unwell and need intravenous treatment, then there are a whole host of antibiotics that can be chosen, but these are the common ones that we use, usually as single therapy, occasionally as dual action treatment. And then Pseudomonas is a more resistant type of bug to treat, and so we use a different groups of antibiotic intravenously, and these are just some of them, but by no means all. And we often use 2 antibiotics together, because it's probably more effective, but also it's likely to reduce the risk of developing resistance to the antibiotics. These are the sorts of things that your medical team may want to know when they see you in the clinic for a checkup. So, have you taken antibiotics to treat an exacerbation since you last had a review? And what were your main symptoms when you were unwell? Because it's sometimes exacerbations, the symptoms can be less clear. And so it's just important to ensure that antibiotics are being taken appropriately. Which antibiotic did you take and for how long? Did you send a sputum sample at the time? Did the antibiotic work well? And was it associated with any side effects? And as a consultant looking after people with bronchiectasis, if people can provide me with this information, it's not that uncommon to have spreadsheets and all sorts of very accurate data, but it certainly makes my life easier to give advice if people have this information on hand. So now I'm going to move from treatment of exacerbations to chronic suppressive therapy. So we often prescribe antibiotics on a regular basis, a continuous basis, with a view to improving symptoms, reducing the frequency of exacerbations, improving quality of life, so reducing symptoms, and then ultimately to try and prevent progression of bronchiectasis. But as you will know from media and concerns about antimicrobial resistance, there are concerns about giving antibiotics on a long-term basis. So there is a resistance issue. You can take out one type of bacteria by using regular antibiotics, but that creates a hole that other bacteria or fungi can fill. You can get tummy upset and specific GI upset with long-term antibiotics. And of course, any antibiotic treatment can cause toxicity, which may be ears or gut or liver or kidneys. So we need to think about these things very carefully. So the best evidence that we've got for long-term antibiotic therapy is for macrolide antibiotics. And these macrolides are antibiotics like azithromycin and erythromycin. And there have been 3 really exceptional studies in people with bronchiectasis. There's the EMBRACE study at the top there that was performed in New Zealand, involved 141 patients, and the regimen was using azithromycin 500 milligrams 3 times a week, commonly Monday, Wednesday, Friday. Then there was a second study of azithromycin, the BAT trial performed in the Netherlands, and that involved 83 patients. And that involved a slightly different regimen of azithromycin. This was 250 milligrams every day for 12 months. And then there was another exceptional study looking at the use of erythromycin in patients with bronchiectasis, and this was performed in Australia, and it involved 117 patients, and they took erythromycin twice a day for 12 months. Now, the great thing about all of these studies is that they showed that macrolide antibiotics reduce the frequency of pulmonary exacerbations. And this is the result from the EMBRACE study. And you can see that this graph shows the proportion of patients who were free of exacerbations. And you've got the azithromycin group in blue, and you've got the placebo group in red. And you can see that after approximately 100 days, 50% of patients in the placebo group were free of exacerbations, whereas in the azithromycin group, it was approximately 85% of patients. And so a really marked treatment effect. The interesting thing about the macrolide antibiotic studies is that it's unclear if the reduction in exacerbation frequency was due to its effect as an antibiotic, or whether it has anti-inflammatory or immunomodulatory effects that result in the clinical improvement. You may then ask about what about other types of long-term oral antibiotic therapy as a chronic suppressive approach? Well, there's actually very, very little data to support the use of these antibiotics, although we use them commonly in clinical practice because anecdotally they do appear to work very well. But the best non-macrolide oral antibiotic trial dates back to 1957 and was sponsored by the Medical Research Council in the UK. And it involved 122 patients who were randomized either to taking oxytetracycline or penicillin or placebo for 2 days a week for a year. And it showed that particularly in the oxytetracycline group, there was a reduction in the amount of sputum and the purulence of sputum, and that patients had less time off work. But interestingly, in clinical trials back in 1957, they didn't actually perform formal statistical analysis. And so this is just a report of the data as it was presented. So now I'm moving from oral antibiotics as a chronic suppressive therapy to inhaled antibiotics. And I guess the benefits of inhaling an antibiotic is that you get very high concentrations of drug within the airway, i.e. at the site of infection. And you get much higher concentrations than you would if you have the treatment intravenously or by mouth. And by going straight into the lungs, you have less side effects in terms of toxicity to kidneys and liver, and you get less side effects in terms of diarrhea and potential for Clostridium difficile. And on the whole, inhaled antibiotics are prescribed to people with bronchiectasis with chronic Pseudomonas infection. And this is because Pseudomonas is associated with worse clinical outcomes. So people with Pseudomonas tend to have more frequent pulmonary exacerbations, more frequent hospitalization, and a worse quality of life. And the antibiotic that is used most commonly in Europe is one called colistimethate sodium or colistin. And this is a polymyxin type of antibiotic that is active against Pseudomonas. And there have been two recent international trials called the PROMISE studies looking at the effectiveness of this intervention. And there were two 12-month studies looking at colistimethate sodium or colistin delivered through the INEB compared to a placebo in patients with Pseudomonas. And there was PROMISE 1 that was conducted in 12 countries, 86 sites, and PROMISE 2 conducted also in 12 countries and 89 sites. What I would say is that PROMISE 1 started first and PROMISE 2 followed up, and that will be relevant as you will hear later. So I'm going to present the PROMISE 1 results and then later come on to the PROMISE 2 results, as you'll see there is some difference in the outcome. So this is what's called the primary outcome, the most important finding from the study, and that's the mean or average exacerbation rate per year. And you can see that in the CMS or colistin group, the average was 0.58 exacerbations, and in the placebo group, it was 0.94 exacerbations. And this gave what's called a rate ratio of 0.61 in the colistin in favor of the colistin treated patients. And what this means is that compared to placebo, the colistin treated patients had a 39% reduction in exacerbations, which is highly clinically as well as statistically significant. And it also showed that treatment with nebulized colistin was extremely effective in reducing severe exacerbations. And by that, I mean exacerbations that needed treatment with intravenous antibiotics or admission to hospital. And in patients with severe exacerbations treated with colistin, there was a 59% reduction in severe exacerbation rates compared to placebo. This slide shows the impact on people's quality of life, and you can see that in the placebo in red, quality of life was pretty stable over the 12 months, and in the blue there is an improvement. So a reduction is an improvement with this quality of life measure, and after 12 months it was a very marked improvement in quality of life in the PROMISE 1 study. And this shows the reduction in the amount of Pseudomonas in the sputum of patients taking colistin, and there was what's called a 1.6 log reduction, so a very significant reduction in the amount of Pseudomonas in the lungs over the 12-month period. Now, unfortunately, life is never straightforward, and as I said to you earlier, PROMISE 1 started first and PROMISE 2 followed up. And you can see in the bottom panel here the results of the PROMISE 2 study. And while PROMISE 1 was showing highly clinically significant improvements in the annual exacerbation rate, there was no improvement whatsoever in PROMISE 2. And you will very reasonably say, well, why might that be? We can't say with absolute certainty, but as it happens, PROMISE 2, over half of the clinic visits were performed during the COVID-19 pandemic. And so we thought very carefully about how the pandemic might have affected these outcomes. And you may have noticed through your own experience that during the pandemic, people with bronchiectasis tended to have far fewer pulmonary exacerbations, and we think that this is because of shielding and isolation and mask wearing, that respiratory viruses were not being transmitted between people, and so people were not exacerbating as often. And so if you look at this, this figure here, you can see at the top, we've got the data from the phase 2 study of nebulized colistin, then PROMISE-1. And then we split the PROMISE-2 study into the pre-COVID phase, so before the pandemic hit, and then the COVID phase. And for data points on the left of the main line here, this suggests that nebulized colistin is beneficial and helpful at reducing exacerbations. And then you can see in the post or COVID phase of PROMISE-2, it's on the other side of the line. So it does suggest that there is something very unusual happening during the COVID phase of the pandemic. And so if you accept this as an explanation for why PROMISE-2 was not showing a benefit, and you just look at the data that was taken outside of the pandemic, i.e. before the pandemic hit, you've got the phase 2 data, PROMISE-1 data, and then just the pre-COVID phase of PROMISE-2. And if you do a meta-analysis, which is looking at all the data together, that involved 689 patients, and it showed that there was a 35% reduction in exacerbation rates in people with bronchiectasis. And further work performed by Professor Chalmers, looking at a meta-analysis of all inhaled antibiotic studies in people with bronchiectasis. So this involves tobramycin studies, ciprofloxacin studies, colistin studies, and aztreonam studies. His whole analysis suggests that inhaled antibiotics result in a 20% reduction in exacerbations, which is very significant. So moving on to the final part of my talk, I want to talk about eradication therapy. And we use eradication therapy on the whole for when we identify a new growth of Pseudomonas. And we do it for Pseudomonas specifically because, as I've mentioned earlier, people with Pseudomonas tend to have more symptoms, more exacerbations, more hospitalization. And so there's one randomized controlled trial here that only involved 35 patients with new growths of Pseudomonas. And all patients were treated with intravenous antibiotics for 2 weeks. And then patients were randomized to either take nebulized tobramycin or a placebo for 3 months after completing the IV antibiotic therapy. And after 1 month, the results were possibly equivalent, but favoring the nebulized tobramycin group, with 91% being free of Pseudomonas at 1 month and 77% with the placebo. But after 12 months, 12 months after the treatment, only 55% of the tobramycin patients were free of Pseudomonas and only a third of the placebo patients. And Professor Chalmers has again done a meta-analysis, so an analysis of all the data available. And this has shown that having antibiotics, which may be intravenous or oral antibiotic therapy followed by inhaled antibiotics, is better than just having oral antibiotics or IV antibiotics on their own. And you can see for this pooled data here, that it suggests that approximately 50% of patients will eradicate the Pseudomonas bug using this combined approach. So just to summarize, Haemophilus and Pseudomonas are the most common bacterial infections in people with bronchiectasis. Antibiotics are prescribed for 3 main reasons: during pulmonary exacerbations, as chronic bacterial suppression or maintenance therapy, and for eradication of new infections. I think it's important to just highlight that just because you have a positive sputum culture, it doesn't necessarily mean that you need antibiotic therapy. And most importantly, antibiotics are only one component of bronchiectasis management. It's absolutely crucial to combine antibiotic therapy with airway clearance mucoactive treatments such as hypertonic saline and anti-inflammatory treatments. So thank you very much for your attention.
Thanks a lot, Doctor, for these great presentations that allows us to better understand the treatment according the phases of the disease, if there is an infection or not, or if it's in the chronic phase and so on. So very interesting. We'll have now the Q&A session, and I will begin with the first question. Perhaps it's a question for both of you, Michal and Charles. It's a question about hemoptysis. A patient who has hemoptysis for 4 months, and she can have a normal life, of course, but her pneumologist tells her that it's not important. So what do you think about such a situation of hemoptysis in a case of bronchiectasis, please?
Will I kick off, Michal, or?
Yes, please.
Yeah. Well, I guess with hemoptysis, there are individuals that have what I would describe as streaky hemoptysis or small volumes, and they may have that just at times of exacerbation, or they may have it more chronically. But when you've got streaky hemoptysis, it generally suggests that the airways are inflamed, and that's why they're bleeding. And so if there is ongoing hemoptysis at the time of exacerbation, yes, I would treat with antibiotics and other therapies. Of course, hemoptysis can be of higher volume, and to be honest, that's really quite uncommon. But when it happens, it usually results in hospitalization, intravenous treatment, treatment with medicines such as tranexamic acid that can help stop bleeding. And if hemoptysis is very severe, then you can actually do a procedure called an embolization, where the blood vessels can be blocked up to reduce the risk of hemoptysis. There's much more that we could talk about in this respect, but that's the kind of the long and the short of it.
Yes, I absolutely agree, and this is really what we do, and we usually consider hemoptysis to be just one of the signs that an exacerbation is going on. So it's a good idea to try antibiotics when hemoptysis happens. But sometimes patients can complain of hemoptysis and there's no other signs of exacerbations. And this is what I would also refer to the procedure that you mentioned, Charlie, about embolization, which means clotting up or clogging up the vessels that we think are causing the bleed. And it's not an easy procedure. It takes a lot of expertise, and it's not uniformly successful, but we try it for patients who have really troublesome symptoms.
So thank you very much. Thank you both for this answer. We got lots of questions over here, so we'll try to give some of you in the next few sessions. But there's a really good one that I would like to forward to Professor Howard. There's a question about azithromycin. So azithromycin is naturally not an pseudomonal antibiotic. How does it work in pseudomonas-dominated bronchiectasis?
Well, I've no idea. But the really important thing is that the clinical trials show that it does work. And as I alluded to, it's probably not its antibiotic effect, but its immunomodulatory effect. And it may have an effect on what's called the biofilm, which is a kind of a slimy substance that the Pseudomonas hides in within the airways. There's much research still to be done to try and work out why it's effective, but thankfully it is.
That's good.
Thanks. Thanks a lot for this question. There was a question about for Joyce about the headphones you used, Joyce. Some patients would like to know what it is, please.
Yeah. Well, you can get various, as somebody already said, you can get various varieties if you go online. The one I've got I wore today was that one. As you say, it looks like headlight. You can use it with or without water in it. So those of you that are worried about inhaling steam, you can turn this off and use it just with the air. And there are all sorts of sorts that you can get. I find this one is particularly useful because if I'm out anywhere, especially playing my ukulele, I can put this between my legs, nobody can see me. And also you can use it this way. I can't, to be able to put it on something like a table. And again, that has just the ordinary air coming through. And also you can put the steam in. And it's got, you can have it on low or you can have it on high. And you just use it just like an ordinary fan. But I do find this extremely useful. And it's more normalized. You know, I feel quite normal using this outside because it can be embarrassing if something makes you stand out in the crowd, whereas, as I say, these are quite easy to use. So I hope that helps.
Thank you, Joyce.
I think Dr. Gumine wanted to add something about the
Yes,
tongue.
there were quite a lot of questions, Joyce, on your device. And I want to add that there is actually some data showing that cooling devices on the face, which activates the trigeminal nerve, which are the nerves on the face, activates 12 brain regions widely implicated in the anticipation and perception of breathlessness. So, for example, including the insular cortex, amygdala. So this is why cooling the face can have an alleviation of breathlessness feelings.
Right. Right. One thing I am bothered about is that if you have it too much onto the face, if it can cause any sort of problems with the muscles on the face. I don't know, but I haven't noticed that, but do be careful with that.
Okay, thanks. Mattia, perhaps you had a new question about macrolide.
No, we've asked the one on macrolides, so I was looking for other questions. There is something about embolization that probably we can approach, but probably will be touched in the next few talks about treatments. For Dr. Howard, what is an example of anti-inflammatory treatment that you can do alongside airway clearance and mucoactive treatments?
Well, good question. I guess at the moment, I would probably suggest that macrolides are the only anti-inflammatory that we have access to at the moment. But the really, really great news is that there's a new type of anti-inflammatory coming. It's called a DPP1 inhibitor, and the specific drug is called Bronchiectasis. And it's an anti-inflammatory that reduces neutrophil elastase levels within the airways and is associated with a 20% reduction in exacerbation frequency. And I'm sure Professor Chalmers will mention this later because it's really exciting.
And the very last question, because we're really close to the ending of the time, why does it seem like cold air causes chest pain or change in symptoms? Mikhail, would you like to answer to this?
Can you repeat this, please, Mattia?
Why does it seem like cold air causes pain or change in symptoms?
Yeah, well, I think there's two possible explanations for that. One deals with air pollution, which is known to cause bronchiectasis. So changes in the temperature, usually when it's warmer, not colder, can increase the particles in our environment and cause more reaction and more inflammation. The other has to do with viruses, and a lot of exacerbations are really initiated by viruses. There's some research that says about 50% of exacerbations have some viral component. And although cold weather doesn't really cause a viral infection, it can make your body more susceptible to viruses. So there's more influenza going around in the winter when it's cold. So there's more viruses going around in cold weather. And also the protection of your own body, your ciliated cells, the cells that have the body uses to expel really the secretions and the organisms that infect your body, they're less well functioning. So the beating of the cilia is less well functioning when in cold weather. So you're more likely to be infected. So that is why possibly there's more exacerbations in the winter time.
So thank you very much. We really need to close this session. There are lots of other questions that I hope we will be able to answer in the next few sessions. So we'll have a 10-minute break and we'll come back at 11:30 for the next session that is going to be entitled, Can My Bronchiectasis Be Healed? With the chairs being Bridget Harris and Professor James Chalmers. So see you in a bit.
Thanks a lot.
Welcome back, everyone. We're going to move on to the next session. My name is James Chalmers. I'm the Professor of Respiratory Medicine at the University of Dundee, and I'll hand you over to my co-chair for this session.
Hello, I'm Bridget Harris, and I'm a member of the Patient Advisory Group. I have bronchiectasis. I've had it for about 20 years, though only been diagnosed for about 10. And one of the reasons I really value being a member of the Patient Advisory Group is the opportunities it provides to work together with other patients and professionals to improve the knowledge and understanding and treatment of bronchiectasis. And that's what this conference is about. This session specifically is about can my bronchiectasis be helped? And someone asked a question at the very beginning of the conference in the Q&A on how to relieve bronchiectasis. And that is a big question, but that is the main reason why we run these conferences. And you can find previous ones on the European Lung Foundation website if you want to backtrack and see what else has been said. So this morning, we're going to cover first of all, Ronan from Ireland has done a video on his patient experience. And then we have a talk on bronchiectasis and cross-infection risks, followed by information on how to know if you're getting worse or whether your condition is just the same. So we'll start with Ronan's video. And Ronan is a member of the Patient Advisory Group. He's a clinical neuropsychologist from Ireland, and he's very keen on improving communication between patients and health professionals. So we'll start with Ronan's video.
My name is Ronan Mills, and I suspect I've been living with bronchiectasis for most of my life, but there was a long delay in terms of getting that diagnosis. probably conflicted about it. You know, you're kind of hoping against hope that you're a relatively healthy person. I take very seriously communicating with the medical professionals in my life to make sure that how I'm managing my condition is scientific or scientifically based, but it is but no matter what is there in the literature, or doctors, physios experience with other people and everything, it is very individual, and it is down to my experience and my symptoms and how and that can be different for other people. It's a daily practice, and sometimes it feels a little bit more overwhelming and challenging than on other days. You get into a routine with lots of stuff like the prescriptions and medications that you have on a daily basis, but then there's like the daily respiratory or chest clearances that I do, and I use apps to remind me about that, and I have guidelines that I've taken from respiratory physios before, and I try to keep on top of kind of how that is, because it's a developing field as well, and so they're kind of trying to come up with new ways of managing things. Standard stuff like sleep is forefront of my mind, because I have young kids, so that's a challenge. It's a particular challenge at the moment. But things like exercise and diet and looking after yourself, keeping hydrated throughout the day, and things like those. In the wake when we've thankfully come out of the coronavirus pandemic and everything, but I would have to say that kind of raised my awareness levels of hygiene around people with colds and sniffles and flus and that, and I think that can be beneficial as well. The top one is the sputum. There's no doubt about it. I mean, I produce a large amount on a daily basis anyway, even when I'm well. So it's there, and it's hard to avoid monitoring the quality and quantity of it. But when that changes in quality and quantity, I know that's an indication that I've come to think about the infections as almost there constantly, and that means that they might be getting an edge on me. And if I get a temperature or something like that, that I know that something far more active is required, and I might reach out to somebody. On exertion, you might hear crackles or something in your chest, or those little symptoms, with your chest or lungs, are definitely those indicators to me that I need to double down, or I need to change and upgrade or seek some more support from other people who help. When you're in the depths of it, like anybody would be when you're feeling ill, you kind of feel like, oh, this is going to go on forever. You kind of when you've gone through that a few times, you kind of realize that you might come out the other end again, and what you can do to help yourself come out the other end of it a little bit quicker. Now I feel that I don't want bronchiectasis, but I feel a bit better equipped to have some effect on that trajectory, so that it's a little bit more similar to everybody else, and so I don't feel as alone. So I feel a bit better equipped, and I feel a bit more normal, if you want to call it that. There's an onus or a message there around taking your time with trying to get to know it and getting to know yourself a little bit better so that you can combat it and everything, It's that a balanced view of things, that I would try to be, that it kind of comes back to.
Thank you very much, Ronan. That's fantastic. And I can see from all of the emojis that are coming through, the feedback that we always get from our attendees is that they love to hear these stories of the experiences of people with bronchiectasis. And so we're really grateful to you for sharing yours. We'll come back to Ronan during the Q&A, but we're going to move on now to the next presentation. And now it's a great pleasure to welcome a friend and colleague, Pierre-Régis Burgel from Cochin Hospital in Paris, in France. Pierre-Régis is an expert in bronchiectasis and cystic fibrosis with more than 20 years experience of looking after these patients. And he's going to talk to us about cross-infection risk, which I know is a question we get very frequently during these conferences. So really looking forward to hearing what you have to say, Pierre-Régis.
Well, James, thank you very much, and thank you for the kind invitation. I will try first to share my screen. If else, this one. Are you able to see my slides?
We can, but we can see all of your slides. So you might want to go into presentation mode. That's it. Perfect.
Okay. No, we have done it. So cross-infection is really an important aspect of respiratory diseases. And there's usually a lot of controversy about this topic and a lot of fears also. So I will try to show you within the next 15 minutes that cross-infection is a problem, but you shouldn't fear about cross-infections, because we have plenty of solutions to prevent it and to make it not such of a big problem. So these are my disclosures. None are related to this talk. So the first question is really, what is cross-infection? So cross-infection is the transfer of harmful microorganisms. So it's usually bacteria and viruses, but it could be parasites, it could be fungi. And when talking about bacteria, it could be mycobacteria, for example, tuberculosis, and maybe non-tuberculous mycobacteria in some cases. So it's a spread of infection between people, between pieces of equipment or within the body. And I will detail that. So why should we care about cross-infection? Well, cross-infection means infection. And we know that infection with bacteria and viruses are really important because they cause bronchiectasis exacerbations. You've listened to Charlie Haworth's talk earlier today. He showed you how important is bacterial infection, how important is viral infection. And obviously, these are not the only causes of respiratory exacerbations in people with bronchiectasis. Air pollution, for example, is another one. But this is really important. So the main problem with cross-infection is that it is infection and it may cause exacerbations with deteriorating bronchiectasis, increase in symptoms, and it may have devastating consequences. Then the question is the risk of cross-infection identical for all people with bronchiectasis? We know that bronchiectasis is an heterogeneous disease. There are different causes, and some people have immune deficiencies as a cause of their bronchiectasis. For example, people with primary immune deficiencies, and they may be at higher risk of infection, any kind of infection, but of course also cross-infection. The risk can also increase due to treatments. If you get rheumatoid arthritis and you have treatment with anti-CD20 or other kind of immunosuppressive drugs or high-dose steroids, for example, well, you could get immune suppression and get greater tendency to get infected by bacteria and viruses. This is also the case for certain comorbidities. If you get diabetes, It's very well known, for example, that it's a risk factor for tuberculosis, which is a cross-infection. So then the infection exacerbations, do they have the same consequences on all people? Well, if you have mild disease, it's not the same as compared as if you have advanced Lyme disease. And one more time, if you have multiple comorbidities, well, the consequences of the infection will be greater. So anyone can get cross-infection. The risk may be higher in some people with immune deficiencies, and the consequences of infection depends on the baseline status of your disease, whether you have mild disease, severe disease, and whether you have comorbidities or no comorbidity. So let's get to the heart of this. How do person-to-person infection occur? Well, there are 4 different ways. The first way is a direct contact with contaminated secretion. For example, kissing someone. So you would be able to transmit bacteria. You have some bacteria listed here: Staphylococcus aureus, Pseudomonas, Cepacia, and some viruses, for example, respiratory syncytial virus. You could have indirect contact. So it's exactly the same mechanism, but instead of having a direct contact with a contaminated secretion, you have contact via a hard surface or intermediary object. If you wish, somebody has put contaminated secretion on, I don't know, a smartphone, for example, and then you manipulate this smartphone and you get a contact with this contaminated secretion, which is exactly the same as a direct contact. And then you have contact through aerosols. So some are called droplet, which means that they are high volume particle. The diameter is over 5 micrometer, and they travel over a short distance. So it's a droplet of saliva, for example, when someone coughs, and it usually travels 1 to 2 meters, and it have infective materials that deposit directly through to the skin or to the mucus, to the mouth. So, and one more time, you can get transmission of multiple bacteria, and a lot of viruses transmit this way: rhinoviruses, influenza, adenovirus, respiratory syncytial virus. And then there is something else, which is aerosols materials, but of a small size, and they stay within the air. So they stay for a long period because they are very light. They stay for a long period of time in suspension in the air, and they can stay for a long period of time. So someone had these droplets in the air, and then you come there maybe 10 minutes later, 1 hour later, and then you get this and you inhale this in your lower respiratory tract, and you can get tuberculosis, measles, or various viruses, including SARS-CoV. And actually, if you look at the bottom, this slide was from 2020, but at that time it was not SARS-CoV-2, it was SARS-CoV. So where do cross-infection occur? Well, usually when you talk about cross-infection, it's all about in-hospital infection. So you have media coverage, you have superbugs like Mycobacterium abscessus or epidemic Pseudomonas strains. But, well, this is true, it may happen, but infection can spread in any settings, in daily life, at schools, in banks, in store, government building, at home. So the risk for infection is obviously greater when undergoing a medical procedure, but it can be anywhere. And one more thing, cross-infection can also occur within your own body. If you have dirty hands with bacteria in your hands, and then you put your finger in your mouth or you put your finger in your eyes, then you may get also cross-infection. This is also cross-infection. So James told you that I've been involved in cystic fibrosis for the past 25 years, and this is true. And the CF field, which is obviously CF is not bronchiectasis, there are different diseases, but the CF field has had many problems with cross-infection. And the reason why they had problems is that they were dealing, or we were dealing with highly problematic bacteria. One of them was Burkholderia cepacia, which when you acquire cepacia, it's not for all patients, but it's a small number of patients that may acquire cepacia, but the consequences of getting cepacia is very, very important because the disease usually deteriorates and sometimes you cannot undergo lung transplantation. So it's a huge problem to get cepacia. And in the 1980s and 90s in CF centers, especially in North America and Canada, there were epidemic of cepacia. Then there was more recently a story about interhuman transmission of Mycobacterium abscessus, which one more time can cause severe disease, although the interhuman transmission is not completely established. And then, mostly in the UK, in the 1990s, there were large epidemics of Pseudomonas aeruginosa with very specific epidemic strains that were found in a large number of patients. So this led the CF field to establish guidelines about prevention of cross-infection in people with CF, especially in hospitals, inpatient and outpatient clinics. So the first recommendations were in 2003 and they were updated in 2013. And what's interesting, I think, is how the recommendation evolved over this 10-year period. So first, on this slide, you see recommendations that were established in 2003 and that remain in the 2013 issue of these guidelines. So it's really simple. Well, you should have hand hygiene for CF patients, inpatient setting, outpatient setting, and hygiene for families, inpatient setting, outpatient settings. So this is quite important. The first message, hand hygiene is very important. Sanitizing your hands, either with soap or with hydroalcoholic solution, appears very important. It was then, it was then true in 2003. It's still true 25 years after. Quite important. Avoid socialization among CF patients when they are hospitalized together or when they see each other in the outpatient setting. Minimize CF clinic waiting room, case-by-case participation in activities outside hospital room. Okay, so this was what remained. Then, what's the difference between the 2003 and the 2013 recommendation? Mask use for all CF patients. Well, in 2003, it was unresolved. It was recommended in 2013, and we'll come back to that, both in the inpatient setting and the outpatient setting. Contact precaution for all CF patients. This is for the medical team and allied professionals. At least 6 feet between CF patients in the inpatient setting, also outpatient setting. Perform pulmonary function tests within the CF clinic. Do not perform them within the pulmonary function test lab. And clean the surfaces between patients. How about bronchiectasis? Well, there is not much information in the bronchiectasis. Probably the best information comes from this group, the AMBRAC ELF Patient Advisory Group and the Ear and Lung. So James Chalmers was in there, Peter was there, many patients also participated. Bridget was in this thing. And the tweet said, risks of cross-infection in bronchiectasis are small and should not currently restrict access to specialized care. And I would think it's maybe an oversimplification of the problem. The conclusion is perfectly valid. Risk of cross-infection should not restrict access to specialist care, no problem. The risk of cross-infection are small, where in this, there were probably word constraint due to the tweet format, but this is the risk of cross-infection with Pseudomonas, I think that was referred to. And why is that? And why is that different to CF? Well, in CF, before CFTR modulators, which are new drugs that we got 5 years ago, approximately 50 to 60% of people had chronic Pseudomonas infection. In bronchiectasis, this is data from the Hamburg group. It's about 20 to 25%, and there are differences among countries with more Pseudomonas in the south of Europe as compared to the north. But the magnitude of the infection with Pseudomonas is 2 to 3 times less in bronchiectasis as compared to CF. There are studies, not many, small studies, actually 3 studies, looking at cross-infection with Pseudomonas in bronchiectasis clinics by genotyping bacterial strains. And well, there is some evidence that there could be some cross-infection, not a lot of cross-infection. It doesn't occur very often. And most importantly, there were no epidemic strains and no clinical consequences of this cross-infection. That's why in the 2018 recommendation from this group, it was considered that Pseudomonas cross-infection may exist, or it exists, but it's not a huge problem for people with bronchiectasis. Doesn't mean that we should not be careful, but it's not as it is in CF. So going back to this recommendation, well, there were very simple recommendations in the 2019 things. Patients should be informed that contact with other patients may carry a risk of transmission of infection, and this is true. And this allows patients to make informed decisions about whether to participate in events or not. You should practice rigorous hand hygiene measure, and this is clearly important. And minimize the production of infectious aerosol by conducting chest clearance at home before attending to events. Some of the events may be webinars, such as today, and obviously there is no risk of cross-contamination within webinars. Otherwise, you should be aware that cross-contamination comes first by hands, so avoid shaking hands. In events, in daily life, in hospitals, I think it's not a good practice to shake hands when you have respiratory disease. And venues should have adequate space and ventilations, and basic infection control measure. Do not share your food, share your drinks, share your smartphones, avoid activities promoting close physical contacts. And well, if you get an exacerbation, then you have a high risk of getting viral infection. Well, it's probably not the best time to attend an event, even though it was maybe a long time scheduled. And if you have problematic bugs or you are immunocompromised, you should probably seek advice from your care team before attending events. How about face mask? Well, in this 2018 document, it was discussed, and some patients in online forums recommended face masks to reduce infection risk in bronchiectasis, but the panel recommended against the use of face masks due to lack of evidence of their effectiveness and the risk of stigmatizing bronchial patients. Well, this was 2018, before the COVID pandemic. Now we get used to wear masks, everyone, not only sick people. And this is data, I think, very interesting data from the US, showing you the percentage of patients with 0 exacerbation in blue, 1 exacerbation in pink, 2 exacerbation in light blue, 3 and 4 in these other colors, between 2018 and 2019. So year 1, in a cohort of 900 people with bronchiectasis. So you see that many patients have 0 exacerbation, some have 1, and a small number have 2 or more exacerbations. And you look the year after, 2019 to February 2020. So this was chosen on purpose because February 2020 is supposed to be the outbreak of the COVID pandemic. And you see that it's really stable. The second wind time frame is before COVID for this group, so almost the same data, but this is the year of COVID, March 2020 to February 2021. And then the large group of people who were exacerbating, not exacerbating anymore during the COVID pandemic. And the reason for that was probably related, to public health measures adopted during the COVID pandemic, such as social distancing, personal hygiene practice, including masks. And all of this resulted in a lower circulation of viruses and a reduction in exacerbation. So I think this is probably a good evidence that masks are effective. Which mask? Well, you have surgical mask and you have, some people call it FFP2, some other people call it N95. These are different ways of labeling comparable things. One is in Europe, the other one is in the US. And surgical mask protects you from large droplets, and they don't protect you very well from small droplets, particles in suspension, small particle aerosols. So it's supposed to be less efficacious than N95 respirators, but it still protects. It gives some level of protection. It's not perfect, and it's much more comfortable. Wearing N95 respirators might be a solution in high-risk environments, but you cannot stay very long with an N95 respirator. It's too complicated. It makes you to feel not good, sorry. Let's not forget vaccination for cross-infection. You could get cross-infection with influenza, but the consequences of influenza are less if you get a vaccination. And we get vaccination for COVID-19, for RSV, for pneumococcal, or for whooping cough. For example, for those of you who are in contact with grandchildren, young children, it's quite important to be vaccinated for whooping cough. So in conclusion, the risk of cross-infection is real. It's with viruses and bacteria. You may say also tuberculosis, maybe NTM. There are high-risk situations, social gathering, visit to the healthcare system, meeting with people who have viral infection, exacerbation. And the best approach to this problem is prevention, because prevention works. Vaccination is very important, and we just finished data showing that vaccination is not used enough in people with bronchiectasis. Implementing social distancing and personal hygiene practice, such as hand sanitizing, is very important, and you can wear masks. I would advise to wear masks in high-risk situations. And with that, I thank you for your attention.
Thank you very much, Peter. Really appreciate that. I'll now ask Bridget to introduce our next speaker.
The next speaker is Dr. Peter Hemeny from Belgium. He's a respiratory consultant and a co-author on many bronchiectasis publications, including the European Respiratory Society bronchiectasis guidelines. And he's also a board member of EMBARC, and he's passionate about improving outcomes for people living with bronchiectasis. And today, Peter is going to talk about, am I getting worse or am I just the same? Thank you, Peter.
Thank you, Bridget. Thank you, James, for the opportunity and for introducing me. But I'll have to disappoint you. Actually, Ronan already summarized my presentation in 2 simple sentences. He said, learn to be an expert by experience and learn getting to know yourself. And that's exactly what I'm going to talk about today. So I hope you can all see my screen. So as Ronan already summarized my presentation, I'll talk about my holiday in 2 months from now, which is going to be a site of this temple. This is the Temple of Apollo in Delphi in Greece. And it's a bronchiectasis vacation in a certain sense, because the Temple of Apollo was amongst other the god of health. And it was a very important place in ancient Greece. Delphi used to be the umbilicus, the navel of the world. And aside from the oracle and the generals who would seek advice, also a lot of patients came to there to have alleviation of their problems. Apollo's son is Asclepius, the god who with the stick and the snake wrapped around it, so the symbol of medicine. And his granddaughters look like Hygeia, where we turned the name hygiene from, and Panacea. So it's a really important place. And I imagine a patient 2000 years ago walking up that hill, slowly seeing the magnificent temple. And then when standing in front of the temple, he would see 3 creeds on top of the temple. And you see the most important one there, Gnoti se auton, which means know thyself. And this was one of the very important creeds that the Temple of Apollo, the Temple of Health, told to the sick. And so how to know yourself? How do we go about doing this? Well, I have a few patients who already gave me ideas. They keep diaries. They check how well they slept, because Ronan told you if you have kids, sometimes quality of sleep is low. They check how much they drank, what activities they did, what symptoms they have, which color their sputum has. So I think that's already a great way of learning more about yourself. Learning to be an expert by experience. But when we look at the WHO, we know that the dimensions of wellness are not only the physical ones. So feeling worse, feeling better could be, aside from physical, also spiritual, emotional, occupational, intellectual, environmental, financial, and social. But for the talk of today, and because we're respiratory physicians, we tend to focus more on the physical part of wellness and well-being. But don't forget, as a patient, that feeling worse, feeling better could be non-physical and could be each of these other 7 dimensions of wellness and well-being. Before I'll start out to give you some tips on how to do this in a more maybe scientific way, to learn to know yourself, one of the things I realize when a patient gets worse is that in almost 80% of the cases, it's an adherence problem. Patients tend to taper down their treatment or forget their treatment. And we know from great research that the patient doesn't do that deliberately, but has a sort of equilibrium between motivators and barriers. And those are treatment-related factors, like a strong belief that your treatment is necessary. These could be disease-related factors, like you feel that your symptoms are or aren't problematic. This could be health-related, to having a good contact with your GP or your specialist. This could be personal factors, like being motivated, being confident in doing your treatment. And finally, also very important, social factors, having a good social network. But what we do in the first place, and you will probably have encountered PROMs, which are patient-reported outcome measures. We use them in trials and in clinical practice, and they're very helpful. You can use them at home, but most of the time you will use them in the waiting room, where you will answer certain questions. We collate the results and we give a certain score, and we can use them on a micro level. With your doctor, he's going to look at your patient-reported outcome, and it will help in making decisions, prioritizing, and setting goals. But the advantage of these questionnaires and patient-reported outcome measures is that they will also help on a meso and macro level, on a population level, to do health planning, to do program evaluation, to set priority and goals on a more population level. So how do we make these PROMs? Are these just random questions that we make? No, certainly not. we look at what matters to the patient. We look at overall health, well-being, quality of care, and we look at certain outcomes within those problems, like morbidity, mortality, clinical assessment. And by using all these elements, we have the production of a patient-reported outcome. This could be generic, which could be applied to the whole population, but this could also be disease-specific. And I will show you a few examples of, I think, really concise, practical patient-reported outcome measures that you can use. But before we can use them, we need to know that they are reliable, valid across different countries and cultures, and interpretable. So that's what we're going to do, and then we can use them in clinical practice or sometimes patients even at home. The first one is the bronchiectasis impact measure, and it's really looking at the quality of the symptoms. So on the left side, you will see a visual analog scale, 0 having no impact on your daily life, 10 greatly impacting your daily life, and asking this on 8 symptoms: cough, sputum, breathlessness, tiredness, daily activity, overall health, control of your disease, and chest infections. And we know that these scores nicely correlate with other quality of life, shortness of breath, global health index, and bronchiectasis severity. We also have 2 other questionnaires who are slightly different. This is the Bronchiectasis Health Questionnaire by Arietta Spino. This doesn't look at the quality of the symptoms, but more at the frequency of the symptoms. These are also a very concise way of looking at your patient-reported outcome measure. It's looking in the past 14 days, have I been tired? All of the time, most of the time, a good bit of the time, up until none of the time. And by then using the collated score, you can then know how your disease is evolving in a certain way, because this questionnaire also correlates really well on the left-hand side with not only lung function, but with your exacerbation frequency, hospitalization, and other quality of life questionnaires. And then there's a lesser known maybe, but a really great third one, which is the bronchiectasis exacerbation and symptom tool, the BEST score. And it's also qualitatively looking at 6 major symptoms: breathlessness, fatigue, sputum volume and color, cough, and cold and flu-like symptoms. And you give them a score, and then you can follow up this from day to day. And I show you a few patients from this paper, and this is not true for all patients, but for some patients, this is a great tool at predicting an exacerbation. And you can see here, the red squares are times where the patient had an exacerbation and received antibiotics, and you can see a significant increase in the BEST score. But of course, we don't only use the history and the symptoms. We would like to have a little bit more of evidence to help you know yourself. Or we could learn you how to use a stethoscope and listen to your lungs, or maybe feel your lungs like the physiotherapist does. But I think the easiest one is to look at the color of your sputum, because we know from research that the more purulent, the more greener your sputum becomes, the more severe your disease is, the more percentage increase in exacerbations you will have, the increase in mortality you will see, and a lower quality of life. So seeing a change in the color of your sputum is already telling you quite a lot, because what it reflects the underlying process. On the top left corner, you see CXCL8. This is a substance which is pro-inflammatory, and it's linked with the color. The more purulent, the higher that substance is in your sputum. Neutrophils, the inflammatory cells, are also higher and more purulent sputum patients. And the same accounts for the substances that cause the damage in the lungs. Those are also more abundant the more your sputum becomes purulent. So we had clinical, we had symptoms. Ideally, you want to have a third element, which is biochemical. But of course, you would need blood sampling, probably. Well, maybe there's in the future one exception. And this is something where James has done quite a lot of work on, and it's neutrophil elastase activity. You've seen this slide from Charlie's presentation. the higher the number of bacteria, the higher the number of elastase activity. And if you treat the patient, even if the patient is stable with antibiotics, you will see a significant decrease in neutrophil elastase. Because the neutrophil elastase levels are linked with event-free survival and with survival as a whole. And this is the anti-inflammatories. I've seen a lot of questions on anti-inflammatories, and James is probably going to talk about the trial results at the end of the day. And I don't want to spoil too much, but there is actually great data from brensocatib showing that the effect on the activation of this neutrophil elastase. So we can stop the activation of neutrophil elastase, and it has a good amount of effects, which James is going to talk about later. But can we do this as a patient? Well, maybe not yet, but as you can see on the left-hand side, there's something called the need stick, which is a practical way of detecting the level of neutrophil elastase in a sort of COVID-like stick that we know now since the COVID pandemic. We all used one of these probably. And so maybe if we make it more practical, this could be something for the future. Because we know that these need sticks are very practical and they link also with survival. The higher the levels of need stick, the lower the survival. And they also link with worse lung function, the higher the need stick grades, which you can see here on the left side. And also the higher your bronchiectasis severity is going to be. There's a few other things that we could use in simple biochemical terms, which is the number of blood platelets we know is also linked to bronchiectasis severity. Neutrophils, of course, but also in 20% of the patients, eosinophils. And we know that on the right-hand side, you can see that patients with a high level of eosinophils have much worse disease than those with normal levels of eosinophils. Or if you have no eosinophils at all, but a high number of neutrophils probably, then you also have an increase in severity. And we see this in other research as well. Those patients, though 20% of the patients with, aside from the neutrophil inflammation, also eosinophilic inflammation, have worse disease and a higher number of exacerbations. So maybe we should look at other colleagues from other specialties. And I'm looking at the rheumatologists. They have something called the DAS score, the disease activity score. And in fact, if you look at that score, they have clinical signs from investigating the patient, the joint scores, the number of tender and swollen joints, they can click. They have biochemical tests, a simple CRP or sedimentation rate, and they have a patient-reported outcome measure, the global health of the patient. And by using the formula down below, they calculate how active the disease is, and they can compare it with previous values, and they can act upon it. They can then decide, is my patient getting worse? Is he stable? Do I need to increase or change treatment? And you can see a lot of these elements you can already, as a patient, learn to know yourself, learn to be an expert by experience. So how do I dream that this could be a thing for bronchiectasis clinics when you come to the outpatient clinic? Well, we might have you do a patient-reported outcome, do a coloring of your sputum. If you have sputum, I think that's the most difficult bit for some patients. And then maybe the need stick grade or maybe a small blood sample, which then gives us a total score and will not only inform the patient, but also the doctor, whether or not you're getting worse or stable or better. But in general, my presentation could just be summarized by Ronan: learn to be an expert by experience and get to know yourself. Thank you.
Thank you so much, Peter, and great to finish with a clear message at the end there. So now we're going to move into a Q&A session. So we'll have Pierre Regis, yourself, and Ronan joining us for the Q&A. So Bridget, do you want to ask the first question?
Yes, I had a question for Ronan, and I was wondering whether you could say what chest clearance methods you find particularly helpful.
I've seen a few people and some physios in the NHS in the UK where I used to live were very hot on active cycle breathing, and you can Google that and look it up. I've adapted that myself, and I don't want to be like hawking devices or anything, but I know other people have mentioned some elsewhere, and I have some power breathe devices, and they're focused on trying to improve inspiratory and expiratory muscles. And so I tried to do a bit of active cycle breathing with those. So I've kind of come up with my own way of doing it, that probably reflects a kind of what Peter was saying about kind of getting to know yourself and that, and is trying to do something. I was doing that to try and be proactive as well, I guess. Yes, it's kind of like doing what suits you. I think is probably the message behind there, as opposed to trying to like hawk certain devices. I wouldn't recommend everybody goes out and buys that. It's like, find something that's going to fit in your life and kind of like motivate you. Things as well.
Thank you. I think most patients would entirely agree that that's really important. And you find something that you can do that works for you.
On the patient website of the ELF, and there's some movies on autogenic drainage and active cycle of breathing technique. So please, for those of you who have questions on this topic, go to the ELF website on bronchiectasis. There's some great movies there showing how these techniques can be performed.
I've got a question from Wendy White in the Q&A, Pierre Regis, about cross-infection. The question's, in light of the CF experience, should people with bronchiectasis avoid mixing socially and avoid in-person patient support groups?
Well, I think even in the CF field, CF patients are having social events together. So I don't think you should exclude this kind of events. I think there are important events, and meeting people is always important, and discussing is always important. Then you want to minimize risk. So minimizing risk means vaccinations. It means if you get an exacerbation, you get a cold, maybe it's time not to go to the meeting, and do not shake hands. Use, I'm not sure, James, how you call that. They say elbow something. It's in the
the elbow greeting.
elbow greeting. It's very popular. Some people do not kiss other people. Some people do hugging. Well, maybe. And sanitize your hands with hydroalcoholic solutions, and wear a mask in events. And this will go perfectly fine. The risks are very small. If you apply this, the risks are very small. So please do not be afraid about cross-infection risk, but consider it seriously and use preventative measures.
Yeah, I think a useful way to put this in context is everything we do in life, it has a risk associated with it. So not just meeting other patients, going to the cinema or going to a restaurant or traveling on a plane, the person sitting next to you might have a virus. So you need to have an understanding that there are risks with everything that we do. And as long as we're informed and we do the best that we can to mitigate those, I think that's the right approach. Peter, a question about disease progression. So we've had this through via email in advance. Do you recommend that patients should get regular CT scans to look at whether they're getting worse?
So the CT scan on a regular basis is more prevalent, I think, in the CF community because they have more clear guidelines. I think in bronchiectasis, we don't have clear guidelines. However, I will say that you need to do regular CT scan if you feel you're getting worse, or if you have an acute infection, or you feel that something's not quite right. Having a new CT scan can show what's going on. Is it mucus plugging? Is it bronchial wall thickening? Is there maybe signs of non-tuberculous mycobacterial infection going on? So this could be really informative, CT scanning. And also note that the dosage level, the irradiation dose, is rapidly going down as opposed to 10 years ago. So the dosage of the ultra low dose, for example, is equivalent to only like 3 chest x-rays. So the radiation dose goes down. It gives you a lot of information. So yes, I think we can use CT in a follow-up of a patient. And I would like to add one more thing. There is quite some research on AI and linking AI and the findings on CT with inflammation indices in research. So it might give us in the future also some information on the underlying inflammation, but that research is ongoing.
Yeah. Okay. Bridget?
I think we kind of can move seamlessly from this Q&A through to the discussion. So we'll just carry on. And there is a question in the chat for Pierre Regis, really. Somebody's asking, what's the difference between infection and cross-infection?
So cross-infection is supposed to be, as I defined it in my talk, an infection between two patients. So not necessarily patient, between two individuals. So you get your infection from an individual, but you could get your infection from environmental exposure. It's the way it's supposed to be, for example, for non-tuberculous mycobacteria, even though this is not that clear. But it's really from cross-infection is from person to person, and it may be direct cross-infection or indirect cross-infection.
Thank you.
So the topic of the discussion that we're having just now is, can my bronchiectasis be helped? And I hope the answer is yes. Otherwise, why are we here? But I guess I'll reframe the question a little bit. What are the best things that we can do to help bronchiectasis? And if we start with Ronan, thinking about your journey with bronchiectasis, what are the things that you found most helpful to cope with the condition?
Like really solid communication with your professionals, like your doctors and that. And like I'm trying to summarize it because a lot of these things can be very complicated because there's so many things going on. But like communication with them over the years, I've gotten a better handle on that and what they're looking out for and what's kind of like concerning me. And then the daily practices that I do, whether that's like taking the medications or the exercise and the airway clearances and everything, those would probably be like my top two, and in terms of like the questions that are coming up around some of the guidance and that, and like assessing and judging risk, I suppose, in terms of like mask use and shaking hands and events that you go to and everything. Like I would totally own, and like my experience is that is like you need to assess and judge the risk. And you're using all that information that your professionals are giving and the stuff that you're seeing and everything is really important, but it's really difficult as well. And I suppose like recently what I did was I avoided my mum's birthday. And what I would say is like that was actually like really upsetting. Like for me, for her, it was a difficult thing to do, and I was full of doubt about whether that was the right thing to do or not. And I have come to the conclusion it was right, but then at other times I do like really weird and high risk things. Like I play jujitsu, and you're coming into like really close, intimate contact with people that, like, frankly, who are not used to kind of looking after themselves, never mind like other people, that kind of a way. And so like you need to get a handle on like why you might do different things at different times, and it's like your own well-being, others, are the things circulating in the environment and everything, as well as what Pierre was saying about like those things that you can do to minimize the risk, like vaccinations and everything. So there was a lot in there: communication, daily practice, and like getting used to how you put all those domains together, that the domains of wellness that Peter was thinking about and how they interact and everything. But that's complicated.
Thank you very much, Ronan. That's really helpful. And I'm sure lots of people will find it so. That we have produced, the Patient Advisory Group has produced a patient checklist to help people communicate with their medical staff. And I will put the link to that in the chat. It's on a page on the European Lung Foundation website, which also has a lot of other information that people may find helpful with their bronchiectasis. And I had had a question for Peter. Somebody has asked, what does it mean when my FEV1 goes down?
Well, when your FEV1 goes down, it might be a sign that there is more mucus plugging, that there's more bronchial wall thickening going on. And so this could be a reflection of underlying inflammation or disease that's getting worse or is ongoing. So I think you need to check that, but don't forget that when you're getting older, from the age of 30 somewhat onwards, your FEV1 is automatically going down. The only difference is that when you have bronchiectasis, and depending on whether or not you have Pseudomonas, this goes in an accelerated fashion. And James will show this in the late afternoon with the trial results of the brensocatib, but this is maybe one of the first anti-inflammatories that might somewhat hold the accelerated decline. But as we all age, our lung function goes down. So the question really is your lung function going down more rapidly than it should? And that should always be an alarm signal of underlying problems.
Yeah. Building on that, Peter, there's lots of, and for Pia Regis as well, there's lots of questions in the chat about exacerbations, which obviously contributes to lung function decline, recognizing exacerbations and what patients should do when they get an exacerbation, and also if they feel they're having a lot of exacerbations. I'll to you first, Peter, but then it'd be great to get Pia Regis to come in on this as well, because I think this is an important set of messages for people.
The first step is the exacerbation pulmonary, or is it something else? Because you can get short of breath, for example, when you're having cardiac problems, and it's a known comorbidity in patients with bronchiectasis. So when you're feeling short of breath, for example, then you should check whether or not it is the bronchiectasis that's giving you a problem, or a comorbid condition like cardiac problems, for example. If it's increase in mucus sputum production, and if you know yourself and you feel like you have a change from baseline, then I think you should seek immediate attention with your GP or with your specialist. Yeah.
And Pia Regis, if people are having frequent exacerbations.
Yeah, what would be the exact question, Jim? Sorry.
So the question is, what should patients be thinking about, or what should patients be asking if they're having frequent exacerbations and they're worried that their condition may get worse?
Well, Peter talked about knowing yourself. This is one part of the story, but I think another part of the story was put forward by Ronan, which is communicate with your team. And I think communication in case of exacerbation is very important, because it means that you've been there for a regular visit, you had a sputum sample taken, so we know which bacteria are within your lungs, and we can give you an advice on the best antibiotics for the next exacerbation, in a way. And I think the care model which has been built for CF cannot be completely exported to the bronchiectasis field, but having respiratory nurses that can receive phone calls or emails or any kind of messages and communicate real time with patients is so good. I mean, you give first line advices and you take first line treatment. And if it works, everybody is very happy. And if it doesn't work, then you get a second advice with the doctor, which is much more specialized and may look for different things. As Peter said, there could be differential diagnoses, new bugs, different complicated things. But most of the time, it's very easy, and communication is key.
Yeah.
Sorry, go ahead, Bridget.
Yes, I was just going to agree. And that really helps if there are respiratory nurses. The coverage is rather patchy, which is difficult. James,
I have experience with the respiratory nurses that went really well, but then I moved to an area where I don't have them. I don't have access to that.
Yeah.
You kind of feel it.
Yes.
Yeah. but Joyce in the earlier one talked about like writing out the issues that she goes in when you only have like restricted access to the consultants and everything, and that kind of preparation time. Then I've found it helps when you don't have like as good access as well.
It does, and don't forget that you can take someone with you if you want, and that can often help because somebody else is listening to what's being said, and that can help you remember it better. They can take notes, but no doctor will mind you doing that.
Absolutely. There's a number of comments in the chat around communication and access to care. One, Elaine saying she had 9 infections over 13 months and wasn't referred, which so I think some of us are very lucky and have access to specialist nurses and very good care teams, and others less so. It's very difficult because bronchiectasis care is quite patchy across Europe. There's lots of questions, Pierre-Regis, in the chat, in the Q&A that I would summarize as questions with people saying, should I get RSV vaccination? Should I get COVID vaccination? Which should I get? How often should I get these? Difficult question, I know, but you touched on this in your talk. Can you summarize what our patients should be doing?
Sure. So vaccination is really an important aspect because in many cases it prevents you from getting the infection, and sometimes it doesn't prevent you from getting the infection, but it prevents you from getting severe infection. This is very well demonstrated for influenza vaccination, for example. So my advice would be not to think too much and just to follow the recommendation by the international societies or the governments for vaccination. These recommendations are usually made by really knowledgeable experts, and they're easy to follow. And this is what we do in daily practice. So for example, you do influenza vaccination every year, and you do pneumococcal vaccination every 5 years, and you do COVID vaccination as often as recommended. And so with new vaccine RSV, I mean, it's now there is not that many data on RSV in respiratory diseases, and the reason for that is that we had no drug to treat patients. We had no ways of assessing RSV infection, but now it's part of the PCR kits that we use to make fast diagnosis in patients. And we see that many patients admitted to hospital for respiratory disease, asthma, COPD, bronchiectasis, cystic fibrosis, they have acute RSV infection. So if we have a vaccine, I would strongly advise to get the vaccine. And maybe we'll end up with, I don't know, 5, 10 vaccines for different diseases. And then the problem, I think, at some point, we need combinations of vaccines, because it's really complicated now to, at each visit, you talk about 5 different vaccines with your patients.
To add to Pierre-Regis, in terms of vaccination, because patients might now think, do I need to get 5 vaccines every year? Some of these are yearly, of course, like Pierre-Regis said, COVID and influenza, and those can be given at the same time. But some of them, like the pneumococcal vaccine is a lifelong vaccine, or maybe needs a boost after 5 years. The RSV data show now that there's a protection for at least 3 years. Probably after 3 years, it's waning a little bit, but we need more data on that. The whooping cough, same thing. It's 1 boost after you're an adult or when you become a grandparent, for example. So not all of these vaccines need to be given every year. So that's also a very important thing. These are long-time investments in your health.
Yeah, maybe a slightly difficult question for both of you, but just that recommendation is clear, and it's been in our guidelines for as long as I can remember. And when we look at the data, the target across Europe's that 75 to 80% of people should be vaccinated, and vaccination rates for our patients with bronchiectasis, COPD, asthma are often much below that. Any thoughts as to why, and if there's anything that we can do to to boost that?
Well, if I may start, well, for a patient to be vaccinated, there are several steps. The first step is probably for the healthcare professional to prescribe the vaccine. So maybe we're not doing it the best way. Maybe some people do it, some people don't. Some people forget about it. Some people have, I don't know, strong beliefs that it doesn't work, or I don't know, so they don't prescribe it. So this is one. But then the second step is the patient has to accept to perform the vaccine, and then it needs to be easy for him or for her to get the vaccine. So the example of France, we were not very good. And what happened was that 5 years ago, there was some new laws allowing not only doctors and nurses to make vaccine shot to patients, but also pharmacists. So you go in the pharmacy and you get not only your vaccine, but they inject you the vaccine directly. And it increases the level of vaccination because it's so much easier for the patient. It's not, I go to my doctor, he prescribes me the vaccine, and then I go to the pharmacist, I buy the vaccine, and then I need to go back to the doctor or to the nurses for injection of the vaccine. Nobody does that. People have lives that they need to go with.
Yeah, I agree with Pierre-Régis. You can see that in Belgium we also have a very low uptake, for example, of the pneumococcal vaccine. It's three pillars. It's the patient, it's the healthcare professional, but also the government, reimbursement, providing information. Those three are the big hurdles. But it's possible. Look at the COVID pandemic. We have in Belgium an uptake of more than 90% of vaccination, but as opposed to only, I think, 10 or 20% in the groups that need a pneumococcal vaccination. So tackling the three pillars, the patient, the healthcare professional, and the government, they all need to be aligned in order to have an increase in vaccination uptake. Yeah.
I don't know if anybody would like to comment on, we're having some comments that people find they get ill after having vaccines. And I think it might be useful if you said something about that.
Okay, I can handle that. So a few things. Everything you do in life has consequences. If you choose not to get a vaccination, then you get no risk of the vaccine, but you get full risk of getting an infection and exacerbation, sometimes severe exacerbations. If you get a vaccine shot, then you get you reduce your risk of viral infection, bacterial infection, exacerbations, but then you get the risk of the vaccine. So then there are several questions. With the vaccines that we have for respiratory diseases, can we transmit the disease? And the answer is very clear, it's no. Can you experience signs of illness following a vaccination? Well, usually not, but you can have some kind of reaction to a vaccine. You have pain in your shoulder. You have you may experience a fever for 24 to 48 hours. Sometimes it happens, and also it may be bad luck, because sometimes you are in the process of getting a viral infection which is not yet apparent. And then you get your shot, and at the same time, you get the symptoms of the viral infection that occurred. This has been very well demonstrated for influenza vaccination. There are fantastic studies about that, getting virus search in all vaccinated patients, comparing patients with symptoms, no symptoms. So life is complicated. There are multiple things going on, but let's put it this way. It's not that you will have no symptoms after a vaccine shot. You may have mild symptoms, but the benefit of getting a vaccination is so much greater as compared to not getting a vaccination.
Yeah, that last point is
come in there?
Sorry, please do, Ronan. Yeah.
Yeah, like, I mean, it's totally anecdotal. I know how the scientists hate the anecdote and everything, but like, to back up Pierre's point, I suppose, like in my anecdotal experience, you know, whereas I was like, I get the vaccines whenever I can. I'm the first in line. I've had an issue with my own GP when I didn't appear on the list for the COVID vaccines because the new issue took people off or because I was under 65, I got taken off of it, even though I have the chronic condition. I had an issue with him and everything. But I always tried really strongly to get the vaccines. And I would say is that like I always consistently, unfortunately, get symptoms from them. But the symptoms are relatively mild, you know, they last 24, 36 hours. I don't usually even need to miss work or anything, you know, like I can keep going. And I would, and they're not universal. Like I can get an exacerbation or, you know, what some other people would call a flu, maybe, you know, over the last 10 years. But there was 2 occasions of the last 2 years when my wife went down like with a really serious flu, you know, like she was laid out in the bed for like a whole week and I was sleeping in the same bed with her, and with my underlying condition it just made no sense why those 2 occasions they really stood out. I was totally fine. I didn't get any exacerbation or any kind of like increase in my symptoms at all, and they were like 2 big ones that I feel like I managed to avoid, you know. And yeah.
Yes.
I'm a devotee. Sorry.
Yeah, me too, very much so. Having had 2 really serious infections, one of which was polio and one was viral encephalitis, which are vaccine preventable. I really, really would advocate it. We're so fortunate that even way back in the 18th century, people started thinking about this and helped us to have methods of preventing disease by vaccination.
If I may add something, a long time ago, this was 30 years ago, I did my military service in Africa, in a country where people were not vaccinated. It's a nightmare. You see children dying from measles and stuff like that. So vaccination is really something. And because a large number of patients are vaccinated in our so-called developed countries, many diseases are not as bad as they used to be. But vaccination is really important. And when you go to a country where vaccination is not available, then you see how bad it is.
Yeah, I think very clear message on the vaccination point. So thank you to all of our panelists. We've come to the end of our discussion session. I hope there's been some really useful messages there for you. We're now going to have a little break. It's 12:45 CET. And so we'll ask you to come back at 13:25 CET for the next session. And a big thank you to Peter, Ronan, and Pierre Regis for all of those really useful presentations and messages this morning. Thank you.
Thank you.
Thank you.
Thank you.
Thank you. Thanks very much.
About self-management and supporting well-being. I am Elisa Kombatsiari. I live in Thessaloniki, Greece, and I was diagnosed with bronchiectasis in 2011. I have been a member of ELF's patient advisory group for bronchiectasis since 2021, and it has been one of my best decisions in my life, I think. It really helped me understand this condition, and it was great finding others with it. I would like to, I'm sharing the session together with Michal. Michal, would you like to say a few words about it?
Yeah, thank you very much, Elisa. And I think it's great to be back and host this 3rd session. I think we have a lot of exciting talks. So for those who haven't been in the morning, my name is Michal Steinberg. I'm a professor of respiratory medicine with an interest in bronchiectasis and CF and NTM. And I'm a member of the EMBARC management. I've also been associated with the ELF in coordinating the activities of the bronchiectasis patient advisory group as an expert from EMBARC. And I would like to introduce a patient video from Donatella Nobile, who has been in the morning session and will also host the panel following. Donatella Nobile lives in Trieste in the northeast of Italy and was diagnosed with bronchiectasis 12 years ago. Donatella is keen to improve the quality of life for bronchiectasis patients across Europe and aims to do so through her involvement with the ELF Bronchiectasis Patient Advisory Group and the Italian Association of Bronchiectasis. So Donatella, thank you very much for preparing this video and sharing it with us.
So if we can watch Donatella's video first, and
I
then
think,
again.
oh yes, okay, we're going to do the video first, and then Eliza, you're going to talk about daily activity.
Thank you, thank you.
Ciao, sono Donatella, ho 47 anni. Nella mia città ci sono parecchie salite che tante volte sono per me una difficoltà perché ho le bronchiectasie. Ho scoperto di avere questa malattia 12 anni fa. Limitato molto l'attività fisica, sono diventata molto più sedentaria, ma trovavo moltissime scuse per non fare attività fisica, come non mi sentivo la forza delle gambe, quando mi alzavo di scatto mi girava la testa, oppure il cuore che pulsava fortissimo anche nei semplici movimenti, non solo mentre salivo le scale. E poi avevo anche paura degli effetti collaterali delle medicine, specialmente per la rottura dei legamenti. Non è stato facile trovare un corso adatto per me. Inizialmente volevo rifare le stesse cose, quindi giocare a pallavolo, giocare a tennis, ma non era stata l'idea migliore. Così mio papà, parlando con il suo insegnante di ginnastica, che frequentava dei corsi per cardiopatici, ha chiesto un consiglio e ho scoperto così il corso di ginnastica posturale. In questo corso io ero la più giovane, però è stato molto importante per me inserirmi nel gruppo, sentirmi accettata nei miei difetti, specialmente con i colpi di tosse che invece in altre occasioni disturbavano le persone che si allenavano con me. E così ho trovato un'attività fisica che vada bene per il mio ritmo e che ne traggo sicuramente, ne traggo beneficio sicuramente con la gestione delle bronchiectasie. Per trovare di nuovo uno stile di vita per convivere con le bronchiectasie, secondo me la prima cosa da fare è non guardare quello che fanno gli altri. Ognuno di noi è diverso e soprattutto ognuno può trovare la sua stile di vita semplicemente anche provando più volte qualcosa, ma non mollare mai. E è secondo me molto importante camminare sempre un pochino, tenersi attivi, è sempre meglio anche poco, ma non stare più sul divano o sul tuo letto. Noi per esempio dell'Associazione Italiana Bronchiectasie organizziamo dei corsi online e una delle nostre insegnanti è una persona come noi, quindi ha adattato veramente il corso di Pilates piuttosto che di yoga veramente all'esigenza delle persone, alla nostra condizione, quindi non ti senti in difficoltà. E poi tante volte non devi anche cadere nel rischio di voler far tanto, tipo 10 ripetizioni, 8 ripetizioni, forse un po' di meno, ma fatte bene ti aiuta comunque. Non metterti mai alla prova a guardare quello che fanno gli altri, quello che dico io. Prenditi il tuo ritmo sempre. Quindi, oltre alla fisioterapia respiratoria, fare attività fisica ti aiuta a gestire molto meglio anche tutti quei colpi di tosse che hai. Certo, ci vuole molto impegno, disciplina e molta disponibilità a fare dei sacrifici, perché il tempo te lo devi gestire anche con gli impegni casomai familiari, piuttosto con le ore di lavoro, ma ritagliati sempre un pezzo della tua giornata per te stesso e per stare meglio con i tuoi polmoni.
That was so great. Thank you, Donatella. It was so inspiring. It really is difficult for some of us to include exercise during the day, but it is important. And here we have a small survey we did among our patient advisory group for bronchiectasis. It was answered by 12 members of our group, and we have some data. So for airway clearance techniques, a wide variety of methods are used, but by most respondents, half using positional variations and about half using a variety of devices. Sessions last from 8 to 60 minutes, with an average of about 25 minutes a day. Most members take bronchodilators daily, primarily long-acting ones that are most often administered before airway clearance techniques. About half nebulize 1 or 2 times daily with hypertonic saline. Some are also using inhaled antibiotics. About half do nasal rinses 1 or 2 times a day. As for exercise, most do something at least 3 days the week, if not more, averaging 30 minutes each session. Regarding hand washing, almost everyone prefers soap and water, washing regularly after being away from home or using the WC, as well as before food preparation or eating. And almost everyone drinks 2 liters of water each day. And now we can move on to our speaker, Professor Pamela J. Maxane. We are so honored to have you here today. Dr. Pamela J. Maxane is a professor of medicine at the University of Texas at Tyler, in the USA. She is an accomplished physician specializing in pulmonology, critical care medicine, and infectious lung diseases. Most recently, Dr. Maxane works at the University of Texas Health Science Center in Tyler, Texas, where she is principal investigator for approximately a dozen clinical trials in bronchiectasis and pulmonary NTM disease. So really, we are so happy to have you here. Welcome, and the floor is yours.
Thank you so much. Let me share my screen. Can you see my screen? Are we okay there? Yes? Okay. I am just so honored to be part of this important event, and I have tremendous respect for my worldwide colleagues, and I'm just thank you for including me in this this patient event. And boy, that video really hit home so many excellent points that Donatella made during that video. I'm showing you here 6
Pamela, could I just
representative.
ask if you to go into presentation mode so we
Excuse me,
can
thank
see?
you. I sure will.
Thank you,
Okay.
yeah.
I'm showing you here 6 representative images of my wonderful patients, all of whom are unique in and of themselves, but all of whom have to do airway clearance and cough daily. I couldn't resist the opportunity to talk a little bit about airway clearance because it really does improve your day, your health, your lung function, and the trajectory of your disease. And exercise is a big part of that. And I want to explain why exercising can enhance the airway clearance. So to take a little bit of a step back, I wanted to review the cough with you, what happens in the normal cough. Now, you all know cough better than I do because you're probably coughing so much more than the average person. But when we really think about what's happening there, when you go to cough, your chest takes a big, deep breath. It gets really big. Your glottis closes. The glottis is sort of the structures that block off the airway, above the vocal cords. And then the chest begins to contract, and that contraction builds up a huge amount of pressure. And then the glottis opens, and all that pressure comes out, and there's this explosive, turbulent airflow. And that's requires a very normal airway, a very elastic airway to manage that pressure. And the problem in bronchiectasis is that the structure of the airway is no longer elastic, and it can't manage and stay, firm in that big explosive event. So you can cough your heads off sometimes, and you feel like you've just got to get that sputum out, and you're coughing and coughing, and it doesn't always work for you. And even if you do cough and cough out sputum, there probably is a lot of sputum left over. So I want to talk about how exercise can impact this. Furthermore, when we are talking about bronchiectasis, we don't always refer to what happens in the much smaller airways. So there are these little tree in bud opacities that accompany bronchiectasis, and these are really small airways that are plugged, and they're way out in the periphery of your chest. These often are just are not effectively cleared by coughing. So again, you're coughing and it's not really helping your disease process. It's not really clearing your airways completely, and you really have to add on these levels of airway clearance. When you cough, there is, can you all see my, you can see my cursor, correct?
Yes, yes.
I'm showing you a cartoon of an airway unit. This lumen here, this space here is, let's say pretend that's the airway. And the airway terminates in this alveoli. It's the terminal unit of the airway, and this is where the oxygen and the carbon dioxide gets exchanged. When you cough, there's a very big pressure that exerts on that airway to expel the contents that are in the airway forward toward your mouth. When you do these open glottis exhalations, active cycle of breathing that your doctor prescribes, what those procedures do is they move that pressure point further out to the periphery. So this pressure point that occurs somewhat centrally or closer to the central airway, the trachea, with a cough, this gets moved all the way out to the periphery when you do those open glottis exhalations. So that means that some of these really plugged little airways can be relieved of the mucus that's plugging them when you do that open glottis exhalation. And so that's really the physiology that exists behind your doctor telling you to do these open glottis exhalations. It's because it moves that pressure point from a more central location out to the periphery where a lot of your mucus is sitting. So to really just, drive this point home, it's sort of like the toothpaste tube where if you cough, it's like you're squeezing the toothpaste tube in the middle. And when you do this open glottis exhalation, you're squeezing the toothpaste tube from the bottom. Now, this can become a marital issue that that causes fights at home. Are you a toothpaste tube that squeezes your toothpaste from the bottom, or do you squeeze it from the middle? That I'll leave that to couples, but I think it's a good analogy for your airways. That if you squeeze the airway from the middle, you are denying a lot of sputum that's left in the periphery of the airway. So open glottis exhalation doesn't just happen when you're focused on airway clearance. You're actually doing an open glottis exhalation during all sorts of things during your day-to-day life. Many patients will tell me, gosh, my cough is so bad on the phone. I have to get off the phone because I'm coughing. And it's sadly that, a lot of patients will say, when I laugh, I start to cough. And it's because, think about when you're talking and you say words like that begin with an H, like hotel. That is a little bit of an open glottis exhalation there. And of course, when you laugh, it's a event where you're opening your glottis and you're exerting an expiratory force. That's a sign that there's more sputum to get out, and you must exploit that maneuver to expel more sputum. So in no other exercise do you do open glottis exhalation more than when you exercise, because you naturally open your mouth and you exhale when you exercise. So I'm going to transition now and talk a little bit more about the mucus that needs to get out during that open glottis exhalation. So as you know, the airway has a lot of intricate and complex features. You know that the mucus is sitting on top of your airway wall, and that mucus should be mostly water and just a tiny amount of proteins. That beautiful mucus sits on top of these cilia that move the mucus forward. And then there's a complex series of receptors and activities within the cells that make enough water in that mucus so that it can be moved. So on the right here, I'm showing you the active cilia, those little hairs moving the mucus over the airway wall and out into your central airways so that you can cough it out. And as you know, the mucus in bronchiectasis isn't that nice, beautiful, thin, glistening, clear sputum. It's heavier, it's darker, it contains bacteria often, and that's what makes that darker color to your sputum. And when the mucus gets heavier like that and sticky, boy, these poor little cilia, hair-like structures can't move it forward. Exercise can change the properties of that mucus, and it can change how well those cilia work. And so again, one more good reason to include exercise in your regimen. Exercise can repair or restore the imbalance of that mucus, making it easier to move and thinner. And we know from scientists who've studied the cilia movement that when that cilia gets the increased circulation that happens from exercise, that there's better oxygenation, better ventilation of the cells that line the airways so that the cilia can move more efficiently. So a lot is happening when you exercise on the airway level that you don't even realize. that's really helping restore the normal function within your airway. Again and again, we know from studies that exercise improves quality of life. The remaining slides that I'm going to talk about will just be mostly pictures of exercise and discussion of types of exercise. Because if I went into the data, so much of our studies in exercise are limited by numbers of patients, types of exercise, short-term studies, when in reality, we really do know that exercise has tremendous benefits, cardiovascular fitness, and most of all, it improves your quality of life. So I wanted to lift us up with these next slides rather than bog you down in data so that you feel like taking a nap after my talk. Before we get into the types of exercise, I want to make a few comments about when to exercise. We have tremendous extremes of temperature these days that can really negative impact our lung disease. And it's well known that high, hot humidity can really impact our lung function. And I don't need to tell you this. You could tell me the fact that you know when it's becoming hot, it's harder for you to get outside. It's harder for you to walk. The air feels thicker. You're much more dependent on your inhalers. And in fact, we know from studies that the outdoor temperatures when it's hot outside, you actually have a higher indoor temperature, of course, but it actually causes a higher indoor pollution. Now, I don't want you to feel like you need to filter your air inside your house, but tiny incremental changes in the indoor air quality can make a difference for you, and you probably do feel that. So when you have these really extremes in temperatures, in the setting of the cold temperatures, make sure you're wrapping a scarf or some type of covering around your nose and your mouth, which will create a reservoir of warmer air around your mouth. Breathe through your nose and out through your mouth. When you breathe through your nose, the air is naturally humidified by the airway, and it warms the air as it comes down into your lungs. As you probably already do, monitor the forecasts, look for the air pollution content that day. Maybe you might not be able to go out and exercise outdoors on certain days. And if your doctor has prescribed a bronchodilator, such as albuterol, keep it with you. Make sure you have this available to you. So now on to types of exercise. You may say, what are best? What's the best one? Well, actually, I would argue that for all of us, all of them are probably the best, because every type of exercise will benefit a different aspect of your body. And really, we want to have a finely tuned whole body, not just one particular aspect of our fitness. Many of my patients just walk every day. And I try to tell them that I really want you to get out there and do other types of things, especially with upper body exercises, so that you can address as you know, your lungs are in the upper part of your body. We want to exercise the upper body, strengthen the muscles in your upper body so that the lungs have good expansion as you're exercising. So let's start with yoga. You really can't get better than yoga. You get improved flexibility, which we're all losing rapidly as we sit here and listen to this talk. You quiet the mind and you get postural positioning. I mean, how much better that? You've got your postural positioning with your exercise. Remember that when you watch a yoga, you don't have to go to a class. You can watch yoga on the computer at home. You don't necessarily, you can buy a book and follow the pictures. You don't have to go to this high bougie yoga fitness place where you have to pay for it. And yoga exercises can be done in a chair. You don't have to get out the mat and do everything the way a professional yogi would do. Do your best. Just pick some exercises that you can manage and then slowly get better at each exercise and expand your fitness. But yoga is an excellent exercise to start with, and there's an attention to breathing in this exercise that can be beneficial to your bronchiectasis. Strength training. This is where I remind my patients, walking alone is not enough. We must add strength training. Numerous studies, especially, for example, in the field of COPD, have demonstrated that patients who perform strength training have improved lung function. And if you think about this, think of the anatomy of the chest wall. There's muscles that sort of traverse in between our rib cage. And as you do upper body strength training, that the muscular system that lines the chest wall is enhanced as well. And you become more elastic and stronger with each big breath. So strength training is a very important part that I'd like you all to consider including. And again, you don't have to be starting out with big 25-pound dumbbells. Pick anything up around your house. It doesn't necessarily even have to be a dumbbell. And you don't have to do this at a gym. You can do this at home. You can do this from a chair. You can do this when you're inhaling your saline or you're inhaling your mucoactive agent. You can lift some dumbbells or something heavy at home. This is an important part to not ignore. The swimming pool. Okay, the swimming pool is such an important aspect. If you have the resources to get in the swimming pool, this can help for my patients who have arthritis, have difficulty ambulating. Many of you will ask questions about non-tuberculous mycobacteria that can complicate a patient who has bronchiectasis. And you're all watching from a different area of the world. And this type of non-tuberculous mycobacteria infection affects people in different areas of the world. So this may or may not be relevant to you. Many of my questions ask me, can I get in the pool because non-tuberculous mycobacteria is known to be in water? I would argue that we know non-tuberculous mycobacteria can live in the water as many other organisms can. That doesn't necessarily mean that that is the same organism that can infect your lungs. And the benefits of being in the swimming pool from a mobility standpoint, from a positional standpoint, with the postural positioning that occurs when you swim is so great that it's probably worth getting in the pool and swimming, as long as you're following your cultures and you're talking to your doctor and getting your doctor's approval. But a swimming is a fantastic exercise that if we all could be exposed to a swimming pool, it would be great for us all to do. And then I've chosen to discuss several different exercises here because I think that our goal is to move the whole body, not just walk in this sort of linear fashion. I'm going to focus on this picture on the right here where it's called Zumba. I'm not sure if we have Zumba in all countries, but generally speaking, this is an exercise that my patients have taught me what this is. And I have a whole contingent of, and I see the thumbs up coming up. I see a whole contingent of patients who are in love with Zumba. And what's wonderful about these particular patients is they're all like 80 years old. And they're going to these places where they're dancing and they're listening to this music and they're having a great time. And it's almost as if this activity has taken years off their lives. Like in a good way, like the 80-year-old becomes a 70-year-old because she's having so much fun dancing in her Zumba class. But the activity of opening up your arms, raising the arms above your head, moving your body in ways that it doesn't move throughout the day, this is really important. And throughout those events, throughout those movements, you're opening your mouth, you're having big exhalations. That is the open glottis moving. movement. You're improving your circulation. The muscles all over your body are contracting. And when your muscles contract, the lymphatic system gets activated. You're moving the lymphatics through your system. It's an entire benefit to your whole entire system. I want to tell you about this this other exercise. This is an exercise that I do here. It's called Tabata. It is referred to as a high intensity interval training. Personally, I download this from the internet and I do it at home when I get home. They tend to be short-term videos, short, like 20 minutes at a time. And they do 20 seconds on, 10 seconds off, 30 seconds on, 10 seconds off. They're all very different. But what I want to tell you about these is they may be led and taught by a 30-year-old professional athlete who looks like she's got a perfectly carved body and she's doing these exercises to the highest level, but we don't have to do that. We can walk through it. We can go through the exercises in a very much more basic way. You're still getting the benefit of moving your body. So you don't have to look like the professional athlete teaching this. You don't have to do the exercises exactly the way the teacher does it. Just move the body. Pickleball is a fashionable exercise that I noticed a lot of Americans are doing these days. I don't know what happened to tennis, but everybody seems to be really excited about pickleball. But here, this exercise involves community. It involves strength. It involves moving quickly, fast twitch muscles. These are all beneficial with your bronchiectasis in terms of getting your heart rate up, improving circulation, improving the lymphatic flow, improving airway clearance. So I encourage you to think outside the box rather than just including a daily walk. Find some alternate form of exercise and try it, because one is it can be very rewarding to learn something new, and you don't realize how great it feels to try a different exercise where you're utilizing your whole body. This is absolutely my most favorite activity that I was so thrilled the day I saw this. This is a UK practitioner who instituted dance with his patients. And this couldn't be, this is just, I think, the best thing that I've seen in my entire career, really. Put some music on, find music that makes you feel happy, that makes you remember something that you did when you were younger, that gets your mind in a happier place. We know that you are constantly carrying the burden of bronchiectasis, and you have to do airway clearance every day. And we understand what a burden that is. If you think about a person who has cancer, that's a terribly scary diagnosis, and they go through terrible treatment, but then they get better, and the cancer is in their past, in their rearview mirror. In bronchiectasis, we understand that you carry this burden until forever. And every single day you have to do airway clearance, and you remember. So take the fact that you have to do airway clearance and try to turn it into something that's enjoyable. You will be doing airway clearance if you put the music on and dance. Maybe, you know, and find some friends to do this with, or not. Do it by yourself. Enjoy some privacy in your house and put the music on and dance. So this is my last slide, and I hope I can leave you with some enthusiasm to try new things and put that music on and dance. Please dance for me. I thank you so much, and I wish you the absolute best.
Wow, thank you, PJ. And I think if it was even possible for me to admire you more, I do now after this brilliant talk. It was great. And I think we have some really nice questions in the chat. PJ, I hope you were looking at the chat, because there were really some great comments about what people are doing, especially dancing. We've had a couple of questions about singing. One really interesting question was, is singing, does it do the exercise with the glottis open? So is it one form of open glottis exercise?
Well, it is, but the unfortunate aspect is that then the voice quality is not so great when you're moving the sputum. So I would argue that the patients who sing, I do have patients in choir and really enjoy this. I would argue that they should do their airway clearance first and exercise, get a lot of sputum out, so that they can go and sing uninterrupted and not have to clear a hunk of sputum while in between the beautiful notes that they're singing.
That's great. There were a lot of questions. I tried to take some from the Q&A. So one question maybe for you, PJ, would be someone asked, when I'm riding my bike in colder weather, so under 10 degrees of Celsius, I often hear whistling sound.
Yeah.
What is this, and should they be concerned?
Patients who have an airway reactivity to cold really must be careful outside in the cold weather. And it sounds like this patient is doing great just because they're riding their bike. So to start out with, kudos for them. But in cold weather, the airway swells a little bit. And when a patient with bronchiectasis or asthma are already starting out at a smaller airway because of the disease, the airway can not be as wide and sort of able to open up like a normal airway does. So then in response, it starts out small, and then when it gets cold and it swells, it can really limit. And so that whistling is a wheeze. And so I would definitely encourage that patient to discuss bronchodilator use with a product such as albuterol prior to getting on their bicycle, but certainly talking to their physician about it. Or wrapping their mouth or wrapping their face too.
We've had some questions about swimming in water or being exposed to water, and it's a concern also with NTM, and you've touched that, PJ. So some people asked about is the risk in different water sources the same, like chlorinated swimming pools versus sea versus lakes? So what is there about that?
So that really, I mean, we could have a conference for a week to answer that question. The chlorination issue, non-tuberculous mycobacteria use chlorination in their metabolism. So chlorination does not at all minimize the risk of non-tuberculous mycobacteria. I want to temper much of the data that's out there warning patients to stay away from water. And I want to be very careful here, because I do want you to discuss this with your doctor. But there are about 250 non-tuberculous mycobacteria. And the ones that we're talking about that infect the lungs are very few in comparison. And there are many studies out there that have identified non-tuberculous mycobacteria in the water, but it doesn't necessarily match the one that's infecting your lung. And so that enough should give you a little bit of pause that you don't necessarily have to avoid all water. Second is, many people who avoid water entirely, drink bottled water, don't get in the shower, they still get non-tuberculous mycobacteria. So we have to look at this very carefully and make sure that you're not denying yourself something that really doesn't make a difference in the whole disease course. And then finally, non-tuberculous mycobacteria can be present, but it doesn't always mean that that's causing the disease or worsening the disease. So this really, I think the bottom line is I would encourage all patients who are concerned about non-tuberculous mycobacteria to seek out a doctor who specializes in this disease and this infection so that they can get really reliable guidance and try not to hop on the bandwagon of sort of what's on the blogs about non-tuberculous mycobacteria.
That's great. Maybe we should move on to our panel discussion. There were some questions also for Donatella, but I'm a little bit concerned of time, so maybe Donatella can answer this later on. We are going to post the Q&A. So let's welcome Donatella, James, and also Arietta. Together with Donatella, we are going to chair the session. So Donatella, would you like to introduce Arietta?
Yes, Lisa, thank you. It's very pleasure for me to introduce Dr. Arietta Spino. Is a lecturer in cardiorespiratory physiotherapy practice and research at the King College in London, UK. She's a specialist respiratory physiotherapist and has extensive research experience with a special interest in bronchiectasis.
Thank you very much for having me. It's a pleasure to be here for one more time in the bronchiectasis conference that's organized by patients actually and for patients. So thank you for the invitation.
It's a privilege to have all of you here. This panel is about unusual symptoms. So first, we would like to raise some issues about voice problems patients might have. So some people with bronchiectasis have problems with their voice and speaking. This might be sore throat, hoarseness, getting quieter when they speak due to severe breathlessness sometimes. So would you like to tell us something about why this happens, or if it is a recognized side effect, perhaps from some medication? The questions are open to all of you, but we encourage everybody to participate if they want to agree, disagree, or add anything.
Yeah, thank you. I can make a start with the voice question, Elisa. I think it's not very uncommon, but hasn't really been looked at very carefully in terms of research. So you do find people who have bronchiectasis and report these issues. What I would suggest is, because there could be two reasons for having these issues with the voice. One is the breathlessness, as you mentioned. So some kind of breathlessness management or conservation techniques would help with that, and the breathing pattern. So try to breathe from your belly rather than the upper chest. That would help with the breathlessness. Or getting breaks and rests in between things, that would help as well. But when it comes to the hoarseness of voice, lots of times this is related to excessive coughing. So what I would suggest to people who have that is that they look after their vocal cord hygiene, basically. So first of all, they make sure they have enough hydration, drink lots of water. Avoid caffeinated drinks or alcohol, or try to balance this with drinking water on the side stream. Or avoid screaming or shouting. Try to protect your vocal cords, and even try to have some menthol or sugar-free sweets that can alleviate any hoarseness of the voice. The other thing you could do is, and it's great that I have this question after Pamela's talk, is to actually encourage huffing instead of coughing. So try to bring your secretions up towards your mouth using huff, which is with a glottis open, rather than with the glottis closed during coughing. So this will be generally gentler in your voice. And when you do exercise, if you try also to, if you want to promote your airway clearance after your exercise, try to do some huffs that would be also helpful for your chest clearance.
And yes, can I add that I think it's something that is very common, but not specific to bronchiectasis, because a lot of patients who have actually asthma and COPD also complain about voice changes, and especially when they're ill. So when they exacerbate, their voice changes even more. And as Arietta said, it could be related to increased breathlessness. I think it may also be related to phlegm coming to your upper airways and obstructing and making the changes in the voice. So I would say the key here also is to do proper airway clearance, and that should help.
I also, I'd like to add too, I try when I see my patients to not just see everyone through the eyes of a bronchiectasis specialist. I try to remember other things that could be causing the same symptom. Gastroesophageal reflux disease and chronic aspiration. We all aspirate to some extent, but when a lot of your life is spent coughing, that can often worsen the gastroesophageal reflux disease. So keep a low threshold to seek out an opinion from a gastroenterologist or ask your internal medicine doctor about this as well.
Yeah, I don't have much to add except that dysphonia, so changes in the voice, is also a common side effect of some of the medications that we give. So that's the other thing to be aware of, is some of the inhaled antibiotics can cause dysphonia, most famously amikacin. But also a lot of our patients take inhalers, and thrush is also a common cause of problems with voice. So sometimes it's the disease, but sometimes it's also the things that we give for the disease.
Okay, we pass now at another symptom, where is no sputum, and my sputum change color during the day. What does this mean?
So maybe I'll start. That's really very common, and it's especially disturbing for some patients who need to take a sputum sample in the morning when the labs are open and accepting the samples, but they only have sputum in the afternoons. This is really, people say that they have sputum or they have phlegm after lunchtime or after eating, or in certain times of the day. So the eating issue may be, as PJ has mentioned, that we all have unacknowledged reflux. So and it may be a reflex of more sputum being built up after food is coming down, and also particles of food being mixed up in your phlegm. So you think it's thicker phlegm, it's actually small particles of food being mixed with it. So I would encourage patients to do their airway clearance, or to focus their airway clearance in the times when the sputum is thickest, and each person will know their own self and what's really helpful for them. So if you have a lot of sputum in the afternoon, this is the time to do your exercise or your airway clearance technique.
Great. A relevant question. I know we talked in the morning about coughing up blood, but what about coughing up blood when somebody is on a stable condition, when their bronchiectasis is stable? This is also something that is referred as a symptom. Would you like to give an explanation, maybe, or?
I can start, and coughing up blood is obviously really just upsetting to patients. I think as physicians, we see this all the time. It's so common for us to hear this, but we're not the one coughing up the blood. Coughing up blood can be vary from just tinging the sputum to actually, filling up a cup of blood. So it's really important, I would say, make sure you're quantifying it. I advise my patients to not cough as soon as they start to see the blood, keep a cup nearby so that you can cough up into that cup and you have an objective way to measure how much blood it is. Because if you just cough up into a Kleenex tissue, or you cough it into the toilet or the sink, it can really look like more blood than is actually there. So by coughing it into a cup, we really can quantify it and understand the urgency of the blood. So the reason why you cough up blood is, as you know, the airways in bronchiectasis are distorted. They're wide, they're inflamed. And every airway has an accompanying blood vessel. And we don't necessarily talk about the blood vessel all the time with bronchiectasis because we're so focused on the airway, but that accompanying blood vessel is also inflamed and it's also distorted in size. And so it's prone to being insulted, and easy bleeding can occur because it's already primed to be injured. So this bleeding is not uncommon. And it's also important to consider the blood is, do you feel bad when you're coughing up this blood? If blood is occurring in isolation, it's the only symptom that you're experiencing. That may be just an irritated vessel that happened to reach its limit and just kind of broke loose a little bit. However, if you also feel kind of ill, and you also have darker sputum can suggest a little bit more bacteria, and you may have a little bit of chest pain, or maybe not, or you feel a little tired, or you have a fever. If the blood is occurring in those symptoms, then you need to contact your doctor and get an antibiotic, or discuss getting an antibiotic. But blood in and of itself, if it's the only symptom, it can just be part of the disease. Like you produce sputum every day, you produce a little blood sometimes.
I'll follow up from what PJ has said. Sometimes when we do a CT scan and we inject contrast material, we also see the blood vessels. And it's not unusual to see very widened blood vessels in people with bronchiectasis. And these blood vessels are, they're at risk of bleeding. And while for most people with bronchiectasis who do cough up blood, it's not really a risk. Actually, hemoptysis can be risky, and if there's a lot of blood, so like a cup in a day, a full cup in a day, that really can signal an emergency, and this is can prompt emergency care. Some of the institutions or places would go for a procedure called embolization, which is clogging up those blood vessels and preventing them from bleeding again. It's not universally helpful, but this is sometimes things that we try when the hemoptysis, when coughing up blood is significant and it's disturbing, and it's mainly when it's happening out of the context of an exacerbation, because that's when we think the problem is the blood vessels, and when we should treat this.
Yeah, and I'll jump in and give the other side, as I did before, that although everything that's been said is right, sometimes our patients are also taking an aspirin every day or other medication that thins the blood, or taking medications that make patients cough excessively, like hypertonic saline. And so sometimes hemoptysis can go away just by stopping some of those medications that also irritate the airway. So that's the other side of what we do when we review somebody who's having lots of blood coming up.
That's an excellent point, because I think we have a section on sometimes patients take herbal remedies. We know that aspirin and ibuprofen and fish oil can increase the bleeding. But when you take an herbal supplement, it's not really always known. And so that's a very, very good point, that we need to be analytical about the herbal holistic supplements people are taking.
Okay. So another question is for pain and discomfort. Some people with bronchiectasis get chest pain. Why is this? How can we manage pain and discomfort?
Yeah. Shall I jump in with this one first of all? So there's a study that my friend Tony De Souza did, asking his patients in Newcastle how often they had chest pain. And I think it was up to 50% of bronchiectasis patients reported chest pain at times. So this is not an unusual symptom. This is a usual symptom, I think. And it has lots of different causes. So your chest has lots of muscles and bones, and they can very easily become pulled and hurt when you're doing a lot of coughing and a lot of moving. So that's a common cause of chest discomfort. But a lot of my patients report, for example, a sort of very non-specific bit of discomfort or tightness around the back of the chest or the front of the chest, particularly at one particular time of the day, maybe in the morning. And what I think they're usually describing is that the chest is full of mucus, and the airway tubes are blocked, and they sense that because the airway tubes don't have pain receptors. You don't feel that as chest pain. You feel it as a tightness or a fullness or a feeling of discomfort in the chest, and it's often relieved by doing your airway clearance and getting stuff up. And so I would say the most common one of these symptoms that I get is that it's not so much pain as a feeling of fullness or tightness or discomfort in the chest. And when you optimize the airway clearance and start to get enough mucus up that patients feel clear, that sensation settles. So I think there's lots of causes, but I would say that that's one of the most common that I encounter with my patients.
Yeah, I think it's the question of pain is more a surprise to us clinicians than to patients, because we've all been taught in medical schools that lungs don't hurt. But obviously this is not true. We've been taught otherwise by our patients and life, and this all great explanations. And another possible explanation is the stress in your lungs can cause also pulmonary hypertension. We don't really measure it. We don't speak about it a lot in bronchiectasis, but we estimate pulmonary hypertension in echo studies, but this is usually done while resting. And if people can exercise and elevate their pressure in the pulmonary circulation, this can also cause stress and can cause pain. So this is another mechanism for chest pain. But we all agree this is a very common symptom, but we don't really relate to it. We don't really describe it very well.
And I would like to add,
please.
I would like to add that if your physician doesn't open-mindedly listen to that, it's not your fault. I have found that when my patients can point to the pain, we look at the chest CT scan and match, and it's almost 100% of the time I can match their pain to the aspect on the CT scan where the bronchiectasis is. And although the lungs don't hurt, the covering, the lungs are lined with a thing called pleura. It's almost like the crust of a bread. The pleura is, and the pleura, boy, that is innervated and has lots of pain. And if the bronchiectasis is touching the pleura, you will feel it. And so if your doctor doesn't believe you, it's not your fault. You are correct, all patients. It's true, you have pain.
From the management point of view and the physiotherapy side, if you do experience pain, of course, after your discussion, and if it's because of the secretions, you can try to address this in terms of doing your airway clearance and making sure you insist on that with huffing again instead of coughing, because this can affect how much pain you feel on the chest. And another point is that you could probably try to do some breathless management and relaxation techniques that could help your or distraction. And there was a question about laughing in the chat, which I guess it could really help people with to get distracted at least. So there are some laughter yoga programs that some of them are online or in person that people can try. Although in terms of evidence, we did a systematic review recently and we didn't find any studies for people with bronchiectasis. So we don't know if that's effective or not. There are a few studies for people with chronic obstructive pulmonary disease or lung cancer, but they're quite small, so we cannot really make recommendations based on them.
Okay, then finally, another not unusual, but I think a bit unusually discussed issue or symptom bronchiectasis patients have is sleep problems. This can be due to sleeping positions and the mucus on our lungs, or it can be caused by other factors. Do you have any thoughts or suggestions about it?
I hope I'm not talking too much, but I'll start a little bit. This can take on many different manifestations, difficult sleeping. But to start, when my patients say that I cough when I lie down to go to sleep, I feel like, you're caught red-handed. You didn't do enough airway clearance during the day, because exploit that phenomenon that when you lay down, you cough. Well, that's because when you lay down and have postural positioning, the mucus can drain and you can easier cough it out. So I always encourage my patients, if they experience that event where I lie down, I cough, so it's preventing me from falling asleep, try to do a really good airway clearance before they go to bed that includes that position. Capitalize on the fact that you cough when you lay down. But I think sleep is incredibly important, and I almost included that in the exercise. And if exercise can help you sleep, then that's one more good reason to exercise. But sleep is when your body restores itself. Sleep is when you can recover. It is extraordinarily important, and anything that you can do to work with your physician or even engage in biofeedback techniques to help quiet your mind so that you can get a restorative, uninterrupted sleep is very important, because you live in a state of chronic inflammation. And so to go to sleep and turn things off and recover is extremely important. I bet my colleagues have even better things to say.
Well, I don't have a better thing to say, but this is an advice that I also give my patients, is to do some of the airway clearance just before going to bed, so to clear their lungs, and that will give better sleep at night. And I think it's important for people to realize that this disease, bronchiectasis, and especially in severe states, takes up a lot of energy. This is why you feel tired. This is why you lose weight, because it's a high caloric demand.
Consumption.
So yeah, so you would need more sleep, you would need more rest, you feel tired, and you know that when you have an exacerbation, that's one of the symptoms of an exacerbation. And knowing yourself, knowing your body is very important, and knowing when to stop, and finding techniques that help you rest and eat, and is also very, very important.
Sometimes people have asked about cough suppressants so that they can sleep. This is tough because we really do want you to sleep, but we don't really want to suppress the cough because that sputum down there has enzymes in it that can further damage your lungs, and so we want to get that sputum out. So I try to really focus on the airway clearance as a mode of getting that out before you go to sleep. And I want to also just give a shout out to the various apps that you can pull down on your phone that are biofeedback to help you turn your brain off. Many people can't sleep. We live in very, very stressful, complicated times in this world right now when most of us are really upset about things and thinking about that during sleep. There are apps that you can put on your phone to sort of help focus on quieting your mind and not thinking about the stresses in your life that are really, really effective if you have the willpower to listen to the app.
Okay, then thank you all. It's been a wonderful discussion. I think we really learned a lot from you. And now it's time for a short break. It's the last break, so be back in less than 10 minutes for a very important session, our last session.
Thank you.
Thank you.
Thank you. Bye.
Bye.
Welcome back to the last question. So finding the answers, where we're going to hear about the use of AI in bronchiectasis, and James will provide an update. In the meantime, I'd like to introduce my co-chair, who's just done a great presentation on exercise, Professor Pamela McShane.
Thank you. I'm tremendously privileged to be part of this important event. I've already learned so much. So I'm exceptionally excited to watch what we're going to hear about in the next several talks about finding answers and research for the future of bronchiectasis. Thank you, Alan. I'll send it back to you.
Thank you. And Jeanette can share my slide. So I'm a patient in the UK with bronchiectasis, and this is about the future. And we have a patient action group working with the European Lung Foundation, and there's plenty of opportunity for all of the patients here today to get involved in the group or the e-panel to help with the future. So I've been at this now for 10 years, and I can tell you the changes I've seen working with people like James in the guidelines, in drug therapies, being the patient advisor. There is lots of opportunity for you to contribute to your future, and you're welcome. Whether it's like Donatella sharing your experience on the videos, whether it's planning events like today, whether it's speaking at events like today, we want to hear from you. It's a great way to help you and help your future. Sign up to the PAG and the ELF. There's an email at the bottom, and I look forward to seeing you at the meetings. And I'd now like to bring in Dr. Mattia Negro, who is in the same area that I'm in. He's from Italy. So in my day job, when I'm not doing this, I have an AI business. And I'm professor of enterprise analytics at the UK University, specializing in AI. So I'm very excited to hear about the use of AI in bronchiectasis.
Here it is. So this, I guess, this increases a lot more by the difficulty of this speech. So thank you very much for your kind introduction. I'm really happy to be here. I've been here for the session number 1, and I will try my best now to describe the link between artificial intelligence and bronchiectasis. So can you please confirm you see my screen and everything is all right? Am I right?
Yes.
Okay. So I got no particular personal or financial conflicts of interest to declare related to the content of this presentation. I would like to describe to follow the following agenda in my presentation. So I would like to highlight what artificial intelligence actually is, how can AI help doctors in bronchiectasis, and how can AI help people living with bronchiectasis in managing their own condition properly. So I've divided the whole presentation into these 3 different points. So let's start with the first one. What is artificial intelligence? I guess most of the people in the room have heard about artificial intelligence lately. Everyone is talking about artificial intelligence. Basically, the concept is applying a brain to a machine. But it is actually not true overall, because artificial intelligence is not a proper form of intelligence, because AI does not have a proper self-awareness. So when we think about artificial intelligence, we usually got this kind of vision in mind. So we think about intelligent robots or whatever, these kind of machines that can help us in our daily life, or can maybe even be dangerous in some condition. This is a picture that I asked an artificial intelligence to provide me with. So it's quite of a complex way of thinking about artificial intelligence. But actually, artificial intelligence is a part of our daily life since several years ago, because these are actually examples of how AI interacts with our life since several years ago. So I'm pretty sure that everyone's received some suggestions about the movie that they should like according to the movies that they've liked in the past. I'm pretty sure that we are all familiar with text assistant in our smartphones that can predict and sometimes guide the context of a phrase that we are writing in a given moment. And I'm pretty sure that everyone is familiar with the suggestions about music that we like or this other condition. These are all situations that are driven by AI. So AI is not a big deal. It's something that we are really aware of, that we can live on with. But the explosion of AI in the last few years is actually linked to the development of more sophisticated version of AI. So AI is a machine that can perform a task requiring human intelligence. But there are some particular kind of AI that we call machine learning, that is a subset of AI that learns from data. So machine actually improves their own performances learning from data. And the deep learning is another peculiar type of artificial intelligence and machine learning, in which the way of learning is actually based on neural networks that are a way of processing a good and a very large amount of data. While the generative AI, that are the kind of AI that we have heard about most in the last few years, are based on the interpretation of data and the possibility of AI of generate some data similar to the data that they have been trained on. So models like GPT or the other large language models are actually a way of developing this kind of generative AI. In the last few years, there have been lots of different kind of generative AI. I'm pretty sure that almost everyone has heard about ChatGPT, but Gemini is another one, Copilot, Google Assistant, Claude, iAsk, Chatbot. These are all kind of different artificial intelligence, but they are all based on almost the same architecture and almost the same 4 different pillars that I will show you in the next slide. So every generative AI work with these 4 different these 4 different steps. So the first one is training. So AI learns from example. AI tend to predict, so recognize some patterns in a conversation or in an image or in a certain content, and can understand what you're talking about. Then it can generate some content, and it can receive some fine-tuning. So it can receive some feedbacks on which they improve the content of the generated image, of the generated content that they've provided you with. I'll give you a very simple examples of this. So just imagine that you are training some AI model with dogs or puppy pictures. So the AI gets very good at understanding what a dog is or what a puppy is. Then, I've just done this this morning with ChatGPT. You can provide an additional pictures of a dog and say, what animal is this? And what ChatGPT replied to me this morning is, this is a dog. Specifically, it looks like a Samoyed, known for their fluffy white fur, friendly disposition, and whatever. So the AI is actually good at recognizing some patterns into the picture and to make some logical deduction about the content of your image. And it's able to generate some content. So I've asked ChatGPT, could you please provide a realistic image of a brown golden retriever running into the fields? And I think the result is quite good. But the cool stuff is that you can give them some feedbacks and say, I want it to be more realistic, as it was a photograph. And actually, the second picture, in my opinion, is better than the first one, because it's more similar to a picture and it's more similar to what I had in mind. So this is the way in which generative AI works overall. So it's really important to understand this, because when we talk about AI applied to medicine, we might be scared of that, and we might think that these are these are enemies of medical doctors, opponents. But this is not true, because actually the way in which they work is quite different. Artificial intelligence tend to use statistics, tend to use patterns that they've been trained on, while the medical doctors use judgment, intuitions, they use the knowledge that they've acquired during university school or during the years of practice that they've gone through. Artificial intelligence has no feeling, it's just data processing, while medical doctors feel emotion, show empathy to the patient that they're facing in a given situation. Artificial intelligence only see numbers and information, while medical doctors consider life context and preferences of the people, of the person that they are facing. AI perform well-defined tasks with clear data in mind, while medical doctors can work even in uncomfortable situation, unclear situation in which they need to make very complex decision making. While AI cannot be in human relationship, doctors can comfort and motivate you. So if we think about doing a trip into a foreign countries, actually using artificial intelligence is more similar to using some sort of GPS navigator. It's really good, and it can really tell us what is the best option to go from point A to point B. While having a medical doctor is more similar to have a proper touristic guide that can suggest you, that can give you some advice, and can even personalize your routes and identify the best approach for your own necessity in a given moment. So they really serve different purposes. But the next question is, can AI help doctors in the fields of bronchiectasis? And the answer is most certainly yes, because we got some very few data on the field of bronchiectasis, but I will show you something. So this is a study not conducted on bronchiectasis. It's a study conducted on previous smokers or former smokers or actual smokers, sorry. It's part of the COPD gene study, in which CT scans were evaluated by AI to understand if there was a relationship between the presence of bronchiectasis in people that were not diagnosed with bronchiectasis before and the rate of exacerbation. And what they found is that according to the specific algorithm that you can see here, there were some people with a very high percentage of enlarged airways that, as Professor Steinberg told us this morning, is one of the the main radiological features for the diagnosis of bronchiectasis. And what they found is that the people with no previous diagnosis of bronchiectasis, but with an enlargement of the airways, actually tend to have an increased risk of exacerbation over time. But if we try to translate this work into the field of bronchiectasis, this is a study conducted on EMBARK on 524 inspiratory scans, just processed by human intelligence and no artificial intelligence. We might see that there are lots of different conditions, different structural conditions that are present in people with bronchiectasis. And I'm not talking about just the airways of the enlargement of the airways. I'm talking about mucus plugging. I'm talking about atelectasis or consolidation. I'm talking about arterial bronchial wall thickness and whatever. So it looks like there are different characteristics that can predict outcomes, that can predict quality of life, that can potentially predict evolution of bronchiectasis. And potentially AI could be, but we need to prove this, could be really good to exploit this, to identify this, and to quantify this even better than the human eye. So AI could help doctors in several ways. It could analyze CT scans, increasing the accuracy of the diagnosis of bronchiectasis and increasing the relevation of this kind of radiological abnormalities that that are usually linked to airway neutrophilic inflammation or eosinophilic inflammation or other kind of inflammation. It can potentially monitor daily health data to predict exacerbation before patients actually know that they're exacerbating, thinking about digital devices or this kind of information that can potentially be available in the near future. AI can potentially support clinicians in difficult clinical decisions because they take into account different parameters from the parameters that clinicians usually take note of. And they can provide an estimate of adherence and compliance to treatments because they can be closer to patient compared to doctors in certain situations. And the last point is how can AI help people living with bronchiectasis? That is the topic of today's conference. So we have tried to address this with a study that we have called the AirBE study, Artificial Intelligence Responses on Bronchiectasis. That is a study that we have conducted a few months ago together with the ELF Embark PAG and the ERS Society. We've formulated 15 different questions of different difficulties formulated by people living with bronchiectasis. We have used 3 different generative AI software, ChatGPT, Bard, that is now called Gemini and is the artificial intelligence of Google, and Copilot, that is the artificial intelligence of Microsoft. And then we have asked 28 bronchiectasis experts together with the patients to evaluate the content of the answers, just to be sure that the answers that artificial intelligence provides in response to patient questions are actually valid. These are the steps that we have followed through all the study. So in November 2023, we thought about the study and we have asked the Embark ELF Patient Advisory Group to formulate questions on the clinical management of bronchiectasis that were relevant according to their own experience. Then in December 2023, we have divided the questions into 3 different tiers of difficulty: easy questions, medium difficulty question, and hard question. In January 2024, we have run the query. So we have asked the 3 different generative AI software on the same day, the whole list of questions. And then in the following months, we have asked both experts and patients to evaluate the answers according to certain parameters that I will show you in a second. And then on July 2024, we have presented the preliminary results of the study at the World Bronchiectasis Conference that was held last year in Dundee. So these are the parameters that we evaluated. The reliability is the first one. So reliability means how consistent is the information core when the same question was launched at the same time, in the same room, on the same software, on 2 different devices. So we really wanted to be sure that the answer was not random. So it was, reliable. And the other 3 parameters were accuracy, comprehensiveness, and understandability. So the accuracy is how exact is the core of the answer. And it was evaluated by experts on the management of bronchiectasis on a scale ranging from 0 to 10. So from not accurate at all to 10 that is totally accurate. The comprehensiveness is the evaluation on how complete is the answer, evaluated by experts on a scale from 0 to 10, while the understandability, it actually, it's linked to the language and the way in which the answer was formulated and is evaluated by patients that are the people that should take this answer as for their own evaluation on a scale ranging from 0 to 10. So from not understandable at all to totally understandable. These are the questions that we had with the study. These are all questions formulated by ELF patient representatives. The easy questions were on what evidence will a doctor diagnose bronchiectasis and not another respiratory disease? Or I've been diagnosed with bronchiectasis, what should I do? Can bronchiectasis have different causes? What are the main medications used to treat bronchiectasis? And do bronchiectasis patients also suffer from emphysema? The medium difficulty questions were, what is the most effective airway clearance technique for bronchiectasis? I've been diagnosed with bronchiectasis. How often should I have routine sputum testing? What are the long-term effects of bronchiectasis? Can bronchiectasis be cured with the right medication? And I've been diagnosed with bronchiectasis. How do I know if I have an exacerbation? And the difficulty one where, is it true or false that excluding dairy products from your diet will reduce mucus production in a patient with bronchiectasis? I've been diagnosed with bronchiectasis. If I feel drained and my cough is worse because I have a virus, does that count as an exacerbation? I've been diagnosed with bronchiectasis. How do I know when I need antibiotics? What should a person do to avoid contracting bronchiectasis? And is bronchiectasis a fatal illness? So I will show you the results. The reliability was a little bit better with ChatGPT compared with Gemini and Copilot. Just take into account that reliability is not 100% for all the software. So it means that there's a possibility that if you ask a question to any kind of artificial intelligence, the content of that question might be just random. So you might just receive yes the first time and no the second time. So quite divergent answers are possible according to this experience. The accuracy scores were pretty high, so it looks like most of them are actually between 7 and 9 for most of the scores for all the 3 artificial intelligence devices. So it looks like there are quite high scores, and it's probably the same with the comprehensiveness. You can see that the curves tend to be pretty high for all the 3 softwares, while the understandability scores are maximum for lots of different questions according to the 3 different AI software that were analyzed here. When we made a comparison between the 3 different softwares, it looked like ChatGPT performed overall better compared to Bard and Copilot. But while we were not able to detect any differences according to the difficulty tier division. So it looks like although some questions might be difficult to answer from a clinical perspective, from a clinician perspective, artificial intelligence does not make any difference into the way in which they answer to them. Just keep in mind that for some of the questions, AI tend to highlight their role as not being a substitute for professional medical advice. This is a very important key point into my own presentation. So artificial intelligence tend to declare to you, you should visit a doctor. I'm not your healthcare provider. I'm not a substitute from your professional medical advice. And this is really important because it can potentially increase the disease awareness. It can probably answer some of your questions, but for some condition, you should really see a doctor and see what a doctor thinks for your own condition in a given moment. So to conclude my presentation, I would like to remark that AI is an integrating part of our daily lives. It will probably be a lot more important in the next few years. It could potentially support doctors in the field of bronchiectasis, both in the diagnostic part and in the clinical decision-making and therapeutical parts, probably in the near future. AI can potentially increase disease awareness of patients through answering in a overall good way to the questions that you might be able to ask them. And AI and medical consultation should not be seen as alternatives because they serve different roles, but both of them can be important for your understanding of the condition. And I really would like to thank you all very much for this occasion. I really want to thank everyone that has participated as a patient into the ARB study that I've just presented. And I'm really happy to be here, and thank you very much for your attention.
Wow, Mattia, thank you so much for that very informative presentation. I know I have so many questions, so I expect our audience will. We're going to hold the questions right now and go to our next speaker, and then we'll have a question and answer session at the end of both talks. Thank you. I have the honor to present our next speaker, and it's really common when we introduce speakers to say that this person is the leader, a leading thought expert, in the field. But I really can't emphasize enough how much of a leader Professor James Chalmers is in the field of bronchiectasis and really lots of other pulmonary diseases. Professor Chalmers is the world leader in bronchiectasis. His research guides pretty much everything that goes on in the field of bronchiectasis. And what's really cool about Professor Chalmers is he's also a really good doctor. And probably even cooler than that and greater than that is he's a nice person. And coming from America in today's day, we need more nice people. And so I'm thrilled to introduce our hero, Professor James Chalmers.
Wow, I don't know where I can go after that introduction, but I'll do my best to recover and give you our presentation about the updates on research. Thank you so much, PJ, and thank you, Mattia, as well. I've really enjoyed the conference today, brilliant talks. And just as an aside, I've been using artificial intelligence in the background because we've had a number of questions that have come through from the audience in different languages, and it's wonderful at rapidly translating the questions and translating my answers into other languages. So artificial intelligence has been part of the conference today. But I'm going to switch gears a little bit and talk to you about the latest updates from research. It's a big year. I'm going to have a lot of really exciting things to tell you. And I'm really looking forward to hearing your questions and your thoughts on the data and the exciting developments that I'm going to share with you. Before we begin, my usual disclosure that like many of the speakers, I do a number of research studies with pharmaceutical companies in the field of bronchiectasis. And particularly this time, I'm going to talk to you about a number of new medications, some of which will become available soon, some of which are not yet available. And so I don't make treatment recommendations. Please discuss anything that I show you here with your doctor. So it's a big year, and I want to really set the tone for this presentation as being really a bit of a celebration of the success of bronchiectasis research. So happy birthday to the European Bronchiectasis Patient Conference. This is our 5th conference. When we started it in 2021, it was sort of a, let's see how this goes. And over the last 5 years, it's been incredibly successful. And it's so great that we've had such an enthusiastic patient community supporting us. And the other birthday is that it's the 10-year anniversary of the first patient being enrolled into the European Bronchiectasis Registry, which is really special for us because, as I'll show you, quite a lot of the building blocks of the progress that we've seen in bronchiectasis has been the community that's spoken to you today and the people who've all worked together to do the research that's laid the platform for some of the progress that we've seen. So happy birthday to ELF, Embark, and all of us. So what's changed in that 10 years? Quite a lot has changed. I mean, bronchiectasis was an orphan condition. I think none of us describe it as an orphan condition anymore. We now have big networks of scientists and doctors working together to try and develop new treatments. We've got international guidelines. In 2017, the ERS guidelines told us how we should be treating people with bronchiectasis. And that, again, was very powerfully informed by patients, including Alan, who was one of the first patients to ever participate in an international guideline. And this is now standard for all of the guidelines. But at the time, bronchiectasis was really blazing a trail. We've got much more investigation into the biology of bronchiectasis, and that's important because to treat something, you need to understand it. And so understanding the science is so important. We know more about what are the problems that patients face because we've got data from over 20,000 patients in a registry. And over the last 10 years, there's been a growth in the number of specialist clinics that provide high quality care for people with bronchiectasis. So it sometimes, I think, feels that things move very slowly, and they do move very slowly in research. But in the last 10 years, I think this field has really been transformed. And as you'll see, that's led on to significant advances. But having said all of that and said that, you know, we should celebrate the success that we've seen in this field, there's still a long way to go. And the question and answer that we've been doing today illustrates that there's a long way to go because some patients have a great experience of care and are getting very high quality care. Some are not. And that's illustrated by some of the latest research. So in the last year, we published data on the quality of care for people with bronchiectasis. And on the left-hand side, this is about airway clearance. And here, I'll see if I can get the pointer. Here we studied over 16,000 people in 28 countries across Europe. Only 52% of people have been shown how to do airway clearance techniques. So given how much you've heard today about how important that is, it's clear that we need to do better at providing access to airway clearance techniques for our patients. And if we look on the right-hand side of this slide, this is all of the other things that the guidelines say that we should give to our patients, which is testing for the cause, doing a regular sputum culture, giving long-term antibiotic treatments if they have frequent infections, offering pulmonary rehabilitation. And you can see that while many patients get access to these things, if you set a benchmark of, say, 80% of people should get guideline adherent care, we're not reaching that for any of the things that we recommend that we should do. So my message is that research has made a huge difference and we are doing much better than we used to, but there's still a long way to go before we can say that every patient with bronchiectasis in Europe is getting the kind of care that I think that they should be getting. And there are further developments that are going to come in 2025. So there's new ERS guidelines that will be published this year, and that hopefully will help to stimulate better care. And this was mentioned earlier in one of the talks, and so I've put it in as a slide. We've tried to put the power in the hands of the patient by creating this patient checklist, which describes what the guidelines say that you should get. And my recommendation is that you go to the ELF website and print this off and give it to your doctor. I've certainly had some of my patients give it to me and say, have I had all of these things that the guidelines say I should have, such as testing for the underlying cause? Am I getting a regular sputum sample? Am I getting 2 weeks of antibiotics when I get a chest infection? If I'm having frequent chest infections, am I getting the right preventative treatments? This is intended to give the power to the patient to say, this is what the guidelines say I should get, and so this is what I expect. And so a plug for that, so that we want to see it used more widely. Over the last 10 years, we've definitely found better evidence for some of the things that we know work. I've talked a lot about airway clearance, and Charlie Hayworth talked about macrolide antibiotics like azithromycin and inhaled antibiotics. All of those, we sort of thought they worked, and now we've got really good evidence that they do work from randomized clinical trials conducted over the last few years. But these are currently our standard treatments that are recommended by guidelines. But as I said, bronchiectasis is an orphan condition. The most famous orphan is Oliver Twist, and Oliver Twist is most famous for saying, "Please, sir, can I have some more?" And that's my thoughts about treatment for bronchiectasis as well. We've done better, but please, can we have some more? Because we really need some more effective treatments for bronchiectasis. So how are we going to go about giving you more effective treatments for bronchiectasis? Well, as has been described many times today, bronchiectasis is really a description of damage to the lungs. And how does that damage happen? Well, it happens because the immune system overreacts and damages the airways. And that's caused by these white blood cells, which are called neutrophils. So here you can see them going in the bloodstream. They get a signal that there's something going on in the lung, so they migrate through the tissues into the lung, and then they kind of explode, releasing these webs of DNA, which is the thick, sticky stuff that our patients cough up. And so you're feeling this biology every day, and that's what it is. It's white blood cells. The green color in the sputum is caused by these white blood cells, and they're called neutrophils. I'm going to talk a bit about neutrophils as we go through the presentation. So too many of those cells causes a lot of the problems that we see in people with bronchiectasis. And so we've been working for a number of years to develop treatments that could target these cells. And so I've thought a bit about how I can describe how these drugs work and see what you think about this. So the damage is caused by these cells going into the bottom of the lungs and releasing these chemicals. So this is one of these cells. It's releasing these chemicals, and these chemicals are called proteases. And how can I describe proteases? Well, proteases chop things up. So in a way, they're like your body's scissors. So they're designed to chop up bacteria, but if you have lots of these scissors in the bottom of the lungs, they'll also chop up the tissue, and that causes the damage that you see in people with bronchiectasis, and over time they cause the disease to progress and to get worse. So I've got 3 small children. So I've got some other types of scissors in my house. And these are the types of scissors that you want to give to small children because they're not ever going to chop anything at all. And if we think about the new class of drugs, and the class of drugs I'm going to talk to you about are called DPP-1 inhibitors, what do? They turn the body's scissors that look like this into the ones on the right-hand side because they inactivate these chemicals that cause the damage to the lungs. So the cells themselves stay because you need them to fight off infections. So your immune system is unaffected, but they blunt the scissors. And that stops them from causing damage and therefore hopefully reduces the progression of the disease. So that all sounds wonderful. And in the laboratory, that's a really, really exciting idea. But to prove that it works in people with bronchiectasis, we need to do clinical trials. I think most people on the call will be familiar with clinical trials. But what we do in these studies is that we take a group of people with bronchiectasis, we ask a computer to do something that's kind of like a coin toss, and one group is given the medication, and one group is given a control, which is usually a placebo, a fake pill, in order so that we're not biased, and the outcomes that we see are a proper comparison, a random comparison between the drug and the placebo. And based on what you as patients have told us over the years is important, the things that we usually measure are exacerbations, symptoms measured by questionnaires, and then lung function tests. And those are probably the most important outcomes because they're the ones that you've told us are most important to you and the things that you would like to see improved. So we've now done a number of these randomized studies with an intervention group and a control group to see whether anti-inflammatory treatment can be effective. And the first of these studies was called the Willow study. And I'll not spend much time on this because I've presented this one before, because this was the first study of anti-inflammatories. It was 256 patients worldwide who got 2 doses, either 25 milligrams or 10 milligrams of this medication I'm going to talk quite a lot about, which is called Bronchiectasis. It's a once daily anti-inflammatory pill. And you can see really clearly here that this is levels of inflammation in the lungs. They're the same throughout 24 weeks in people with the placebo pill, and they go down dramatically in people that get the anti-inflammatory. So that tells us that we can reduce inflammation in people with bronchiectasis. And on the right is the frequency of chest infections. And this is the percentage of people having chest infections. Obviously, at the beginning of the study, 100% of people haven't had a chest infection. It's 50% of people at the 6-month mark, and that's reduced to about 30% in people who've taken the medication. So that translates into roughly a 40% reduction in the risk of having a chest infection by taking an anti-inflammatory pill, which is important and very exciting. So that was the first study, and we call this a phase 2 study because it's a smaller study that's designed to show that this is a good idea and that the medication is safe, that there's no safety issues, and it leads on to larger studies. And there's actually been 3 different DPP-1, also sometimes called cathepsin C inhibitors, tested in these phase 2 proof of concept studies. And I'll very briefly show you the results because they show that in every study, we get the same result. So this is now another one. This is got a slightly more difficult to say name. It's BI 1291583 because it's still in development. And PJ, who's chairing today, was heavily involved in this trial. And this is 5 milligrams, 2.5 milligrams, and 1 milligram against placebo over up to a year. And the results at the bottom there are a little bit complicated. So on the right-hand side, I've made them really, really simple. And what it shows is that this is the reduction in your risk of having a chest infection during the trial. And the 1 milligram didn't really work, but the 2.5, and we didn't expect it to work because it's a subtherapeutic dose. The 2.5 milligram reduced the risk of having exacerbation by 34%, and it was similar for the 5 milligram dose. So the results are very similar to what we saw in the first trial, showing that there's a consistent reduction in the risk of exacerbations in people that take these medicines. And then the third study is actually a study that was just conducted in China. China has a lot of bronchiectasis, probably the most cases of bronchiectasis anywhere in the world. And this also tested 2 doses of an anti-inflammatory pill against placebo. You can see there was about 75 patients in each of the groups. And this is the graph. And here you can see between a 46% reduction and a 60% reduction in exacerbations with the people taking the anti-inflammatory pill. So you almost never see this. You know, when we do trials, sometimes you have a trial that's positive, a trial that's negative, a trial that's positive. When you see every trial showing the same result, it means that we're on to something. So every trial is showing that there's a reduction in exacerbations with this type of anti-inflammatory treatment. And so all of those, though, are phase 2 studies. So they're designed to prove that the idea is good, that the medication is safe, and that it's worth going on and doing a big study that can prove it definitively and lead to the approval of the drug. And so the really exciting news in the last 9 months has been the announcement of the results of the phase 3 trial of Bronchiectasis, which is called the ASPEN trial. So this is the first phase 3 trial of an anti-inflammatory medicine. It's also by far the largest trial ever conducted in bronchiectasis. So a huge thank you to the more than 1,700 patients around the world that took part in this study and helped to make all of this a reality. So this included people who had a history of 2 or more exacerbations. It again tested 2 doses, 25 milligrams and 10 milligrams against placebo. And the trial went on for a year. And the primary outcome was how many exacerbations people had. But I'm also going to show you the data for symptoms and lung function, because again, those are the things that I know are really important to you as patients. And the primary outcome was positive. So there was a 20% reduction in exacerbations at both of the doses. Again, the 10 milligram and the 25 milligram gave very similar results compared to the placebo, no big difference between the two. And when we looked across all the different patients that were in the study, I can't show you all of the subgroup data because there's lots and lots of subgroups, but the reduction in the risk of exacerbation was remarkably similar, regardless of which group you looked at. So whether we looked at adults or the small group of adolescents between 12 and 17 that were included in the study, the reduction in exacerbations was the same. People who were already taking long-term antibiotics like macrolides got the same level of benefit. Same if you were taking other long-term antibiotics, including inhaled antibiotics. People who smoked or people who had never smoked seemed to get the same benefit. So this is really encouraging. It looks like this is a treatment that will be effective for a very broad group of people with bronchiectasis who have a history of exacerbations, which is really exciting. Even more exciting, though, we had a discussion earlier about the fact that patients worry quite a bit about getting worse. And we had a discussion about what can people do to avoid getting worse. Well, one way of measuring getting worse is your lung function going down over time. And we know that people with bronchiectasis, their lung function gets worse faster than the general population. Everybody loses about 30 milliliters of their breathing tests or their lung function every year. And what we saw in the clinical trial was that people in the placebo group, which is the gray line here, lost lung function at about 62 mils a year. So that's more than double what you would expect in the general population. So people with bronchiectasis do get worse over time and faster than you would expect from the general population. And this is where we did see a difference between the doses, because if you look here, for the first 16 weeks, everything looks very similar, but then this line flattens off. And so it looks like after a little while, the 25 milligram dose with the Bronchiectasis is stopping the disease from progressing, which is really exciting. So it slowed it down to 24 milliliters per year, which is roughly what I would expect in a person who doesn't have bronchiectasis. Another way of putting this into perspective is 24 over 62 is a 61% reduction in the rate of progression of the disease, which when you put it like that is really, really exciting. So I think this is something that challenges us a little bit. If inflammation is causing the disease to get worse over time, we talk a lot about symptoms and a lot about exacerbations. I'm not sure how often we talk with our patients about what we do about making sure that the disease doesn't get worse over time. And I think this data challenges us to say one of our goals of treatment should be to make sure that the lung function and the CT scan and the other features of the disease stay stable for as long as possible. And it looks like now we've got treatments that can help us to do that. So the other thing that's really important to our patients is symptoms. And this is things like cough and the production of sputum. And so questionnaires were done every few weeks. This is called the Quality of Life Bronchiectasis Questionnaire. Some of you will have done it before. And also for the first time in one of our studies, patients completed a daily diary that takes less than 5 minutes called the BEST diary. And both of these tools gave us very similar results. So if you look at the top here, the purple is the 25 milligram brensocatib, and it's going higher. Higher means better quality of life, less symptoms. And so the 25 milligram dose is giving better symptoms than being on the placebo. Although you can see the placebo does get better. So just being seen regularly by your doctor in a clinical trial makes you feel better. That's a good sign. It means that we're doing something right when our patients come to see us during these clinical trials. But being on the medication makes a big difference. And then when you look in the diary, there's a clear difference between the 25 milligram dose and the others, where on a daily basis, patients are feeling better. They're reporting less cough, less sputum, less breathlessness compared to the placebo group or even the 10 milligram group. So on the basis of this, it looks like because of the lung function and the symptom data, it does look like the 25 milligram dose has advantages. And I think if you gave me the choice of taking the 25 milligram or the 10, I would choose to take the 25 milligram. We've done some additional work to understand this, and this is work that's just been published by one of our PhD students. We measured mucus in one of the brensocatib studies, and this gray line here is the placebo group, and the other two lines are the brensocatib group, and you can see the lines going down. That's the amount of mucus that's measured in the sputum going down. And so we can say actually these drugs, by reducing inflammation, are reducing the amount of mucus that the body makes. And the 25 milligram is giving the best effect, which fits with the fact that it's having the best effect also on symptoms. So this is really exciting. Anti-inflammatory treatments reduce mucus. So this isn't just about reducing your risk of having an exacerbation. It's also hopefully helping to get rid of some of that horrible mucus that people struggle with, that interferes with sleep and all of the things that we've discussed during today. So this is genuinely a breakthrough. I've begun every talk I've given with bronchiectasis for the past 15 years with there are no licensed treatments for bronchiectasis, and that's very unlikely to be the case at the end of this year. Brensocatib approval is expected in the US in August 2025. We can't guarantee that, but all of the signs are suggesting that that will be the case. Fingers crossed that it does go ahead. And brensocatib approval in Europe and Japan is hoped for, I've made a mistake there, it says early 25, it should say early 26, forgive me. So that's aiming for early 2026. And the important thing is new treatments are also entering phase 3 clinical trials this year, which means that hopefully brensocatib, although it's a wonderful birthday present, will be the first of many birthday presents that we will get over the next few years, because we need more treatments for our patients. So I am greedy. I'm very happy to have one wonderful birthday present, but I do want other exciting birthday presents. So in the last 5 minutes, let's ask the question, what's next? Well, let's ask ourselves, does this seem familiar? Many of my patients will tell me whenever they get a chest infection or whenever they get a virus, it goes straight to their chest. So in a person without bronchiectasis, you get a virus, you get maybe a runny nose and a sore throat for 5 to 10 days. In a person with bronchiectasis, that can lead to an exacerbation that can last for 2 to 3 weeks. Have you ever wondered why that is? You know, why is it that a person with bronchiectasis overreacts to a viral infection? What explains this phenomenon of it always going to the chest? Well, again, the biology is starting to help us to understand this. Your airway has a lining with these cells, and when those cells encounter a virus, they produce these danger signals that say, oh my goodness, something's happening here and we need to respond. But people with bronchiectasis overreact by making too many of these danger signals, and that leads to a cascade of lots of inflammation. So what if we were trying to switch off or turn down the dial on some of these danger signals? So if the response is excessive in people with bronchiectasis, is it as simple as like turning down the volume on your radio? I guess nobody has these anymore because we all listen through our phones, but this is showing the difference between me and Mattia. He's got artificial intelligence. I've got 1980s intelligence. But imagine you could turn this down and say, okay, I'm going to reset my system and not have all of these danger signals. Well, that's exactly what some of the new trials are trying to do. So one of the key signals is this chemical called IL-33. And the idea is if you use an antibody, that's a picture of an antibody, you take out the IL-33 or drop it down as low as you possibly can. None of these other things happen, so you don't get the overwhelming inflammation that you get with a viral infection. The exacerbation doesn't happen. And a trial of one of these antibodies is just in the process of recruiting and is expected to finish and report next year. So that's really exciting. It's a different way of targeting inflammation and a very targeted way. And so I really look forward to seeing the results of that study. In the final one that I'm going to mention is targeting Pseudomonas. Now, this has been shown earlier that about 25% of people with bronchiectasis have Pseudomonas infection. Antibiotics is the usual way that we target Pseudomonas. What if we could target it in a more specific way using an antibody? This is a picture of an antibody binding to a bacteria. The advantage of this would be it only takes out the bacteria that we're trying to target and not killing off all the good bacteria that are in the microbiome. And so that's what we've recently tried to do in the laboratory. And we've shown in the lab that if you add patient from bronchiectasis cells to the lungs and give them the antibody, they kill the Pseudomonas very effectively compared to no antibody. And so this is an antibody called Gromubimab that seemed to be effective at clearing the Pseudomonas. And we've now just completed testing this in a trial called GREAT2 that was conducted between the UK and Spain. And the results of the patient trial will be announced in May. And I look forward to talking to you a bit more about that after May. So hopefully something we can discuss at next year's patient conference. But this is an exciting proposition, being able to treat bacteria potentially without the effects of an antibiotic. So there's lots of other things coming as well. This is the pipeline figure showing all of the different medications that are currently in clinical trials. Most of them are anti-inflammatories because the brensocatib experience has told us that this is an inflammatory disease. And ones that are not on this figure include inhaled antibodies, ensifentrine, which is an anti-inflammatory and anti-mucus, and also gene therapy for a rarer cause of bronchiectasis called primary ciliary dyskinesia. So this is a really exciting time for our field, where we've gone in 10 years from having very few things apart from antibiotics in trials to now having a really robust pipeline of new treatments that have the potential to really transform how we treat bronchiectasis. I truly believe that in 10 years, in the next 10-year anniversary when we give this talk, this will be an unrecognizable disease from the one that we treat today because of the extraordinary developments that we're seeing in research. So let's celebrate the breakthrough. This has been built on lots and lots of people working very, very hard, including our patient community. And that's why I put the picture of the iceberg, because the tip of the iceberg is the development of a new therapy. Everything underneath is the building of the patient community, the building of the registries, the building of the science, communities working together, more than 300 centers recruiting patients, and all of those efforts. And building on top of that, new treatments are coming. With that, we should try very hard to improve the basics of what we do. I've talked a lot about drugs in this presentation, but this doesn't take away the importance of teaching our patients about exercise, about airway clearance, about diet and all of the things that can make a big difference to bronchiectasis. And I truly believe we have the potential in the next 10 years to reach a point where we can stop this disease in its tracks, massively reduce the impact of exacerbations, and treat patients earlier so we don't see such severe consequences. And that, I think, is a really exciting note on which to finish. So thank you very much.
Thank you so much, Professor Chalmers. It is exciting. And for those of the US patients who are listening, August 12th, keep your eye on the internet news. August 12th is the day that Insmed will present brensocatib to the FDA. There's so much information just presented there. I don't know even where to start, but I'd like to start with one question, Professor Chalmers. Most patients will be very eager to get their hands on brensocatib, but there are some nuances in the differences between the phase 3 clinical trial inclusions of BI 129-1583. So there may be benefit to entering that trial and foregoing taking brensocatib in the immediate future. Maybe you want to discuss why it might be helpful to go into a clinical trial, even though brensocatib is available.
Yeah, absolutely. I mean, one thing, I said it at the beginning of my talk, but a huge thank you to everybody that's participated in the clinical trial, because you can see now you've changed the lives of hundreds of thousands of your fellow patients if you've done that. So a huge thank you and tribute to you for doing clinical research. Brensocatib is likely not going to be available in Europe, where I practice, until next year, whereas there are trials kicking off now of compounds that are very similar to brensocatib, which you will then be able to get access to much earlier. The other advantage of taking part in a clinical trial is that it's very likely that the drug will be limited to a subset of patients with frequent exacerbations, for example, whereas the clinical trials of BI 129-1583 and other clinical trials are open to a broader population of patients. And I'm quite convinced by the phase 2 data that the drug will be effective for a broader population of patients, including, for example, people who are having one exacerbation per year. So I think there's lots of good reasons, if you're excited by the data that I've shown you, not to only look forward to brensocatib, but also have a discussion with your patients about whether you could get access to a similar medication through a clinical trial.
So on that, I've got some questions from patients of who will get it first. So in the UK or Europe, we've got this early 26. Which is it available to everybody? Is it going to be available to some? And will it replace any existing therapies that people are on?
Yeah, all fantastic questions, Alan, that I probably don't have a perfect answer to. So having been intimately involved in the science and leading the clinical trials, the decision on approving the medication and who it's made available to very much falls into the power of the regulators, which is independent of us. And so in the UK, as you know, it will be NICE and the Scottish Medicines Consortium in Scotland that will decide who it's made available to and at what stage. And so I think watch this space. Based on the data, I really hope that it's made available to as many patients as possible, as quickly as possible.
So I have an AI question, being an AI man. So I know some of the capturing of patient data, like cough on Alexa, and capturing O2 levels through smartwatches would potentially be an area of pre-warnings of things that are happening almost before you come to the hospital. In bronchiectasis, is there any work going on to take the biometric data from the medics and put it with patient-generated data, such as cough and Alexa, O2, heart rate, exercise, in order to provide a more holistic treatment view and early diagnosis? Mattia.
Not that I'm aware of, but it would be extremely interesting. When smartwatches collect a huge amount of data, even the working distances, the VO2, the SpO2, almost everything. So it would be extremely helpful from a clinician perspective to have this kind of information to see if a patient is going good, is he stable, is deteriorating, is worsening. So it would be, yeah, it would be exciting to have this kind of information available.
Well, I know the smartwatches have got FDA approval for things like O2 and heart rate, so there is clinically level data available. We just need to come up with a program, James, as the world leader, of how we take this forward with Mattia as a technical lead.
Yeah, I mean, I think AI has enormous potential applications. I mean, I think about all of this data that we generate from these clinical trials about who responds best to treatments and in term directing the right treatment to the right patient. And I think humans are not that great at integrating very complex data, whereas computers are very good at it. So I suspect there's a lot more than just getting information from chat functions that will come in bronchiectasis from AI.
Excellent.
So sorry, off you go, Pamela.
No, I think you were going to make another comment about AI, and I think that's very helpful. Thank you. You go ahead.
So what's your next step in AI, Mattia, in order to bring this closer to the disease area we're looking at?
Well, for patient awareness, I think we got some ideas over there with the data I presented. The problem is probably that 15 questions is not a big deal, so it's not comprehensive of all the questions you might ask for a given AI. And then there's the issue with the trend over time, because this kind of machine actually increase their knowledge very fast. But potentially you might have lots of different information from there. According to the clinical information questionnaires, EKG, almost everything could be useful into this. It's just that we need to be aware of the kind of technological possibilities that we can have. It's probably more of an engineeristic question. I'm just a medical doctor, so it's even complicated for me sometimes. What do you think could be the best perspective into this as an AI person?
I think that the trick will come from, as you rightly said at the beginning, AI is everywhere. It's in the Tesla car, it's in your smartwatch, it's in your smart ring, it's on your telly, it's on Alexa. And on top of the great stuff we've got in the Embark, it's how you put those two together. So each by themselves is useful, and I think the two together is additive in many, many ways we haven't even thought of, like the drugs we're now coming on. 10 years ago, when I started as patient number 1 here, we hadn't even dreamed of this. This is just a great step forward. And I think we're at the same place now. In 10 years' time, we'll be going, remember, Matt, you did that presentation on AI, and it was all scary and out there. And put the two together, we've got something really exciting. And
looking at different fields, I was just thinking that I think for atrial fibrillation, the international guidelines actually rely on some smartwatches for making a diagnosis and to see the burden of atrial fibrillation. Probably this kind of integration between clinical and AI could be something that we should look at in the near future.
I really hope that AI can change the landscape for those patients or people who can't make it to a specialized center. We talk about how AI is going to make everything more sophisticated for the people who are at these, high-level specialist centers. But we forget, and we don't forget really, that there are so many people in rural settings, especially in the United States, who don't have access, can't afford, the travel to a specialized center. And wouldn't that be wonderful if we could sort of deliver a remote physician or a remote opinion to some of these people who don't have any expertise in care?
And early warning, because the sooner, as a patient, you go in, have I got infection? Have I not got infection? And even as a patient, it's not always clear from the symptoms. And I think with putting that together, we'll get better. And I know there's some other studies going on home sputum analysis kits, which James didn't mention today. So there's also bringing some of the clinical stuff into the household to put with that whole data set is an exciting future. And you mentioned America, you've got India, you've got China, you've got South America, which we think we're badly done to. I think if you go out to there, you're into a whole different world of badly done to.
Yes. We are getting a lot of questions about brensocatib, so I don't want to, I know these are questions, they're building, so I'm going to transition to this topic. Some people are asking, can brensocatib be taken instead of azithromycin? Will it replace azithromycin?
Great question. So in the trials, we looked at that. So some patients took it without taking azithromycin, some patients took it with it. The effect was exactly the same whether you were on azithromycin or not. So it can be taken as an add-on to azithromycin, but it can also be taken by people who can't take azithromycin for any reason or aren't taking it. So at the moment, I don't know where it's going to fit, whether we would give azithromycin first, whether we would give brensocatib first, or whether one will be added on top of the other.
Excellent. We also, I love to see this question, and it has a straightforward answer. How do I get involved in a clinical trial?
So please do.
Join our patient group.
So please do. So I would say, firstly, if remember the request from Alan and Pippa earlier regarding the ELF group. Some of our clinical trials have actually, the whole design has been changed by input from our patients. So you can get involved as a participant, but you can also get involved in helping to run these trials through the patient group. And all of our trials have people like Alan helping to support them. But if you're looking to be a participant in a clinical trial, firstly, please do it. As I showed you, even if you end up in the placebo group, often you see a big improvement in your symptoms. There's great data that even shows people live longer if they do clinical trials because they get looked after so carefully by the doctors. So if you want to speak to your doctor, ask them what clinical trials are available. Believe me, your doctor will be delighted to talk to you about clinical trials, because we're always excited when patients are interested in the new things that are coming. And now's a great time to do it.
We have some questions about, can you take brensocatib in the context of the Pseudomonas infection?
Yes, so about 30% of people in the clinical trial had Pseudomonas. And so you absolutely can take it with Pseudomonas infection. Pseudomonas causes a lot of inflammation. And so an anti-inflammatory in that situation, we think, can be very beneficial.
The question about Pseudomonas, I know the answer, but I'll let you explain it better, is if you've had the treatment and you've eliminated them and they come back, how do you know it's the same, it's different? Is there only one Pseudomonad? And have you got it, you not got it, and does it change?
Oh, what a great question. So we don't usually know is the answer. So if it goes away for a bit and then it comes back, Pseudomonas is an environmental organism. It's everywhere. It's in your sink, it's in the pond, it's everywhere. And so it may be that the one that you had was hiding and it's come back, but it may also be that you've acquired a new one from the environment. There are ways to find out, but it involves doing sequencing of the bug. That's a research tool. It's not something that your doctor is going to do, because actually it doesn't change what we do. Whether it's a new one or the old one, we're still going to treat it with the same antibiotics.
I see a question here that represents a lot of concern I know in my patients is there a way, and this touches on one of the studies that you presented, is there a way to minimize antibiotics? And the person presented the question as they are damaging to the whole body, and I'd love to hear your comment about that phrase. Take it away.
Yeah, so I think that's a really, really good point. We always have to be really careful with this. So antibiotics are very, very effective at making patients with bronchiectasis feel better. So I'm going to say some things. Don't take away the message from this. as being don't take antibiotics. If you're unwell, you need to take an antibiotic. But having said that, every time you take an antibiotic, they're very broad spectrum. They knock out good bugs in your gut and they knock out good bugs in your lungs. And so cumulatively taking lots and lots of antibiotics throughout your life can have knock-on effects. And lots of my patients tell me that they have gut problems and they have, Alan's pointing in his ear because some of them have side effects like hearing problems. So taking lots and lots of courses of antibiotics, while it may make patients feel better for a period, is not the future that I want for every patient with bronchiectasis. And so what I've presented to you is the research that we've been doing over the last 10 years, which is really about trying to find treatments that are better and are not antibiotic based. And so I would love to think that in 10 years, rather than constantly taking course of antibiotics after course of antibiotics, the main treatment for bronchiectasis is anti-inflammatory medicines, which don't have the antibiotic problems, and maybe those antibody treatments that I mentioned that will treat one bug but not wipe out the good ones. And that combination would mean, of course, we'll still need to use the antibiotics sometimes, but less often than we do now. That's the dream.
We also have a question about, I'm jockeying back and forth here between multiple topics, but such are the questions. So can you discuss the side effects of brensocatib?
Yes, I'm really, really glad that you asked me that because I didn't have time to go into that in great detail. The reason I didn't put that in great detail is because in the trials, the safety profile of the drug looked almost exactly the same as the placebo. So that's not to say that it doesn't have side effects. Everything can have a potential side effect, but the number of side effects was almost exactly the same between the drug and the placebo. The main side effect that we saw that was more common and that I think patients might notice when it comes out is what's called hyperkeratosis, which is thickening of the skin. So some of the patients in the trial, very small numbers, 17 people out of more than 500 in the brensocatib 25 milligram group, noticed a little red bit on the skin, so like a rash. That tended to go away if the drug was stopped for a little while, and then it didn't necessarily come back if the drug was reintroduced. Only one person stopped the trial because it bothered them so much. So I don't think it's going to be a big problem, but it's something that I'm going to tell my patients to be aware of. I'll say, take this, it's very effective, but be aware that some people get a bit of difficulty with the skin in rare cases. There was a question earlier that specifically said there's rumors going around on discussion boards that there's problems with people's teeth with these medicines. So if you don't mind, I want to very quickly address that. That was looked for really, really carefully in both the phase 2 studies and in the phase 3 studies. And there is absolutely no signal for an effect on teeth. And we've actually published on this with brensocatib. There's no signal at all. But since that seems to be a rumor that's going around, it's good to knock that one on the head.
There is a question on gene therapy, which is big in things like cystic fibrosis. So you've got PCD, which is more like that. Where are we at with gene therapy in the aspects of bronchiectasis, where it's an inherited gene modified cause?
Yeah, so really, really exciting. So in London, just very, very recently, they started the first mRNA therapy. So that's using mRNA to deliver the gene to the lungs to try and correct a type of primary ciliary dyskinesia. So that potentially could, I don't want to say cure, but massively improve the outcome by fixing the basic defect. Now, it's not simple because CF is one gene, PCD is more than 50 genes. And so you have to develop a treatment not for one gene, but for 50 different genes. And so this first trial is just for one type of gene. But nevertheless, what an amazing development that is. So I think if you've got PCD, this is a moment of real hope that if that works, that could make such a difference to be able to deliver something that fixes the cilia in the lungs directly by fixing the gene defect.
See if we're getting any new, I think we have a question that's a little bit off the brensocatib and AI topic, but one person is asking, should I continue to take probiotics in the context of azithromycin? This is a little bit off our topic, but I think it's a commonly asked question.
Yeah. Do you want me to take that, Mattia?
Yeah, it's fine.
Yeah. So I'm not aware of any randomized studies, but azithromycin and all antibiotics do mess with the gut health. And a lot of my patients say that they feel better taking probiotics. So I say to my patients, if you're having gut issues, by all means, try probiotics. And if they help, that's great.
So that's the same from my experience. Actually, there are some people that have some kind of gut pain or whatever. When they start azithromycin, usually sometimes it gets better over time, and probiotic could be helpful in some condition.
Yeah, I would say if you do get really bad gut problems, diarrhea, abdominal pain with azithromycin, there are alternative treatments. So don't put up with it. If you're really struggling with it, come back and see us and we'll give you something else, because there are other treatments that are effective.
Probiotics is a great example of patients reaching out for something that might help them in a environment, in our current environment of very few options for treatments. And so, I know I probably speak on behalf of all of my colleagues that, our heart goes out to you that you have this daily symptomatic disease and there's not a lot of treatments and there's nothing to absolutely cure it. So we understand that you're looking for some alternative, but as Professor Chalmers presented, there's no time more than now that there's the promise of new effective treatments. So hang in there with us, enroll in these clinical trials so that we can find you something that actually is placebo-controlled, randomized to placebo to the actual drug, and studied in a controlled fashion so that we can give you something that we know works. And also, please engage in studies and trials with AI, because I think there is a tremendous amount of information that you experience from a day-to-day, hour-to-hour, really, time frame that is hard for us as physicians to absorb all in that one visit. And I suspect that we'll have a much better tool to assess your status with AI tools. And I know that I've learned a whole lot from these last two talks, and I hope you have. I'm going to transition the close to my colleagues here, and I wish you all the best.
Okay.
So we are the closing, and there are been a lot of interesting talks in today's conference. I'm sad because this conference is over and it's also my international comfort zone, being with other patients and clinics in the bronchiectasis field from around the world. But I'm sure a new future is near. Never give up. So, Dr. Chalmers, Ellen, and Mattia, other comments for the closing?
No, you said it so well, and I think James's enthusiasm. 10 years ago, we couldn't have a conference because we had nothing to talk about. Things started to get better 5 years ago, and now we have something really exciting for patients to A, become involved in, and B, for patients in general. And the enthusiasm of the medics who've been here today, Pamela, James, everybody's involved in this community and is committed to it. It's a great day, and thank you to all the participants.
I totally agree. So it's been a fantastic conference, and I've been really happy to join you all. Lots of exciting talks, lots of very good news. So fantastic occasion. I leave the word to James.
Yeah, if I could just take a moment to say a huge thank you to the ELF team, Pippa, Jeanette, and all of the members of our patient advisory group. It takes a huge effort to put on these conferences and put together an exciting program, and I'm sure you'll agree they've done a brilliant job. And also, particularly Mikhail Steinberg from our Embark team, who's led so brilliantly the patient activities that have led to the conference today. And as a closing message, I mean, I said how excited I am about the developments that we see. I think the theme for today has been positivity and hope, hasn't it? I mean, we're talking about a chronic disease, and yet every talk today has really been hopeful and positive and about living life in a positive way and finding a way through this to have the best possible quality of life. And I think I just saw a comment come through on the chat saying uplifting. That's how I think today has been. And it's fantastic to be in that position with such a positive community working so hard to make a difference in this disease. So my huge thanks to everybody that's helped to deliver this today.
Sorry, I lost any contact with us.
Great. So I know lots of people are logging off now, but we've got a closing poll just to see. We'd like to see if your knowledge of bronchiectasis has increased.
We close with the last poll of the day, and you answered the first, and we have started with the same. And now, what is your answer for rate your knowledge of bronchiectasis of this after this conference?
That's good.
Great, we are improved.
That's good.
Fantastic. So thank you, speakers, patient contributors, session chairs, Amber, steering committee, our bronchiectasis patient advisor group, everyone who help promote the event, and everyone who could join us on the day. If you want more information about bronchiectasis, then a good place to start is visiting the eHealth Information Hub. You feel a lot of information and resources to help you. We want you to stay in touch with us, so to sync up for the health newsletter. And if you are in a clinic interested in finding out more about Hamburg, the links are on the slide. We hope we have enjoyed our first bronchiectasis patient conference, and the talks have been recorded, and we aim to get them our website in the next 2 weeks. We will notify and delegates by email. A feedback will also be sent to you to tell us what you like or what could be improved. So from me, a final goodbye. Have a good rest of the day, and we hope to see you again soon. Sorry for my English.
It was great. Thank you.